Hi, everyone. Just to introduce myself again, my name is Mary Choi. I'm the president of the Korean American Medical Association. And I hope you have been enjoying the last 2 days of the convention thus far. And today I get to open day 3 of the KAMA convention, and I do this with really high enthusiasm. Today we have special sessions planned that focus on topic of interest of our medical students and residents and fellows, the all-important topic of well-being and mental health. And you're also in for a real treat. A research abstract competition was conducted leading up to this convention, and students and residents from US and Korea competed, and they will be presenting their research projects. I think you'll be impressed by their talents and accomplishments, and I hope you'll be equally encouraged that we have a bright future in these young generation coming up. At this time, I'd like to turn the mic over to Dr. Ji-Won Kim, our KAMA Executive Committee Research Chair, who, with the help of her colleagues on the Executive Committee, particularly Dr. Cecilia Yoon, who worked closely with KAMSA and KAMRAF to organize this session of the conference program. So thanks, everyone, and Dr. Kim.
Wonderful. Thank you so much, Dr. Choi, for the introduction. I want to also welcome everyone to the focus session for medical students and training physicians at our KAMA Annual Scientific Convention. Today, we'll celebrate the accomplishments of our students and training physicians. I'm really honored to be able to start off this focus session. I've had the great privilege of being able to work with KAMSA and KAMRAF, our student and trainee organizations, over the past 2 years as research chair. Throughout this time, we've held a wide range of activities and events, and we've had really outstanding representation by participants from around the country and even across the globe. The KAMA Executive Committee, with Dr. Choi's leadership, has really worked to focus on the interests and priorities of our students and trainees over the past 2 years. These conversations have led to mentorship events, as well as sessions focused on career development, and talks and discussions related to topics particularly relevant for women in medicine as well. In fact, through these efforts, I'm really proud to share that we have had over 200 participants in our newly established KAMSA KAMA mentorship program, which we just started this past year. I know this will only continue to grow as we focus our efforts on the next generation of Korean American physicians. In this regard, I want to recognize the KAMA and KAMRAF board members, as well as its members. I want to especially thank the board leadership I've had the honor of working with, Na-woo Kim, Christina Cho, Eric Yu, as well as Esther Lee, whose vision and ideas were really the inspiration to the themes and focus of many of our events and programs this past year. As Dr. Choi mentioned, our session today features Dr. Francis Lee, who will discuss well-being in medical education, which is a topic that our students and trainees had great interest in exploring, and is really particularly relevant in the current environment where many of our trainees have and continue to work on the front lines, and our education, training, and social restrictions have led to major impacts on well-being as well as mental health. We're really fortunate to have Dr. Lee sharing his expertise with us today in this regard. The session on well-being and medical education will be followed by research presentations featuring our students and trainees, including those in Korea. In this context, I want to highlight that we had a really outstanding showing of abstract submissions across a wide range of subspecialties and fields, as you'll see today during these presentations. All of this work really highlighting the immense talent of our Korean students and trainees today. As you'll see, our top abstracts are being presented as poster presentations, and the top 3 abstracts as oral presentations. I'd like to be among the first to congratulate our outstanding award winners from around the US as well as Korea and recognize their accomplishments today. We're really proud of our students and trainees for their commitment, as well as dedication to research and scientific advancement. We also recognize the mentorship of faculty who are really committed to the success of our students, residents, and fellows. Lastly, I want to thank all of our presenters as well as attendees to this hybrid event, which has really allowed us to maintain the outstanding quality and rigor of our program. Thank you all for your time, commitment, and collaboration. With this, I'll turn the stage over to Dr. Alex Choi, who will moderate the Well-Being and Medical Education session.
Hello, everyone. I'm Dr. Alex Choi. I'm a second-year resident at New York Presbyterian Weill Cornell in New York City. And I have the distinct pleasure to introduce Dr. Francis Lee, who is the chair of the Department of Psychiatry at Weill Cornell Medicine.
First of all, thank you everyone for inviting me, especially the organizers, and attending this session. I think this is one of the most special sessions of the meeting, and I'm so honored to be the speaker for this session. I have a few slides, hold on. I have a few slides, but I would hope to have enough time for a robust question and answer period. Just a little bit of a background about me. I'm a trained psychiatrist, but I'm also a trained neuroscientist. And the area of focus of my research has been developmental neuroscience. And I've become so interested in this period of time between the transition between adolescence and young adulthood. This is a period of time of probably the last time of great brain plasticity in our during one's life. It's also, unfortunately, the time of greatest vulnerability for psychiatric disorders. And to understand why that is, this paradox of great potential resiliency, but also great vulnerability, is something that's a fascinating question. And also, I will say that I think this is very relevant for medical training, because this is exactly that period of time with which you're probably going to go through the probably most stressful components of your training. And let's see if I can get my slides to work again. It seems to always be a little slow for some reason. So this is from a review article I wrote in Science several years ago. What's so interesting is that 75% of all psychiatric disorders emerge before the age of 25. Just to take the case of anxiety disorders, it actually occurs that 30% of American youth have a diagnosable anxiety disorder. And as I mentioned yesterday, the Surgeon General's advisory report that just came out suggested there's a youth mental health crisis due to the pandemic. And and there are many reasons for this, but I just want to point out a study done by Kathleen Marikingis, who basically showed that anxiety disorders start emerging during adolescence, but that essentially without treatment, or even with treatment, they seem to continue to accumulate. And so that access to treatment is actually quite low. Only 20% of the US population gets access to evidence-based treatments for this. So it suggests that it's a progressive disorder that emerges during adolescence and starts to peak by the early 20s, just about the time that most of you are going to starting medical school or in the midst of being in residency. Connor Liston actually did a fascinating study about a decade ago. In the United States, we do a national stress experiment on all medical students by making them take USMLE Step 1 after their second year of medical school. And basically what Connor did was he neuroimaged them before they took their exam, the month before as they were preparing, and the month afterwards. And I won't go through the details of the study, but essentially the 1 month of chronic stress of studying for the exam actually led to significant sort of difficulties in prefrontal cortical processing and brain connectivity of the prefrontal cortex to other brain regions. And that 1 month after the test, that all these functions returned, which really tells you something about the medical student brain, that essentially it is able to be resilient, but that during periods of heightened stress, the prefrontal cortex will essentially go offline. And I'll actually go over some research that suggests why this is so. Also, even before the pandemic, Srijan Sen at University of Michigan had already shown that also in terms of resident physicians, that there was high rates of anxiety and depression, especially during the intern year, which makes complete sense that as you're going through the period of time of greatest uncertainty and sort of shift in your living situation or in sleep cycles, that this would happen. And unfortunately, it has already been borne out by multiple articles in JAMA that essentially during the pandemic, that there's been increases in mental health symptoms among training physicians, as well as PTSD. And he actually reported that also that among physicians, a biomarker for cellular aging, telomere length, was also shortened among residents. And this is probably the most famous developmental neuroscience video that's ever been made. It was essentially a longitudinal study of cortical thickness. And the only reason I'm showing this to you is that it suggests that your prefrontal cortex is still developing even into your 20s. And that essentially there is actually an imbalance in the rates of development of your prefrontal cortex versus other limbic regions, such as the amygdala or the striatum. And that this is sort of borne out in the fact that in very stressful situations or heightened emotional situations, subcortical regions such as the amygdala or the ventral striatum actually overrule the decisions that are being made by the prefrontal cortex. And I think this, if you take anything away from this talk, it's this, that the developing brain from adolescence to young adulthood is one that is in an imbalanced situation. And that this is probably, even though we're still working on it, this is probably the framework with which to think why there's so much increased vulnerability to psychiatric disorders, because that essentially that the prefrontal cortex, which in the future developed brain will essentially be able to control things and sort of provide top-down sort of monitoring of these subcortical regions, is not fully online and it cannot sort of tamp down various emotional or stressful situations as efficiently as in the adult brain. And ultimately, this is probably the sort of neurobiological basis for why there's so much this increase in mood disorders during this time frame. What I wanted to go over is just two sort of quick studies that we've been doing here at Weill Cornell in developing digital psychiatric treatments that have been optimized for the developing brain. And I went through some of this yesterday, but I think I want to go over just a little bit further in greater detail. The largest evidence base for any type of psychotherapy is cognitive behavioral therapy for mood disorders. And that essentially the main disadvantage, and this is also true, I assume, at most of your medical schools and also colleges and high schools, is that we don't have enough clinicians that can provide this very sort of sophisticated manualized type of treatment. And so the question that we had is that for our medical students and graduate students, can we also provide a digital version of CBT that could be optimized for this population? And I went over this yesterday, but essentially we have put every component of CBT into this digital app called Maya, which we developed at Weill Cornell. But we've also now been able to make a student version of it, so that essentially, as you can see, that we've modified it so that it is actually much more relevant to situations for students and graduate students that are going through training. And it's very specified for the stressors that they are undergoing. And what we became so interested in is that as I mentioned yesterday, we're trying to build in various incentives to try to enhance engagement, that we became so interested in the social incentives, because we realized that essentially this might be what will engage young adults much more so than in other populations. And the data for this is actually quite high. And this is work from BJ Casey, who was when she was here at Weill Cornell, but that essentially social reinforcement is actually a greater reward during adolescence than in any other period of time, much more so than childhood or in adulthood. So that if there is socially rewarding situations, can we do something to leverage our engagement by sort of tapping into this sort of window of opportunity within the developing brain. see. So what we've done is we've developed a variety of social incentives, whether they be supportive, collaborative, or competitive, and we're testing them now in a clinical trial. But I think this is sort of the future of how we think we can have developmentally sensitive types of interventions. So essentially knowing that for young adults and adolescents, that a social incentive, for example, doing the CBT app together as a team instead of individually, might actually be much more advantageous than in any other scenario. But ultimately, I think what we are still concerned about is that psychotherapy is very difficult. Are there additional tools that we can use to enhance engagement? And in the last few slides, I'd just like to go over one tool that we did develop. It's called the symptom tracker. We actually developed it to study the brain. We put in symptoms that can be all of this various psychiatric scales, like 100 questions, but using machine learning algorithms that it can actually be done within 5 minutes, or 5 to 10 minutes. We actually deployed this to all healthcare workers at New York Presbyterian Hospital during the pandemic. So we have 47,000 healthcare workers in our hospital system. But I think what we really hoped for was not to just basically provide a convenient digital tool to measure depression and anxiety symptoms. We hoped that the healthcare workers, including health officers, would have an attitudinal shift where they would view maintaining their mental health as comparable to maintaining one's physical health. And then this is sort of gets to the central theme of wellness. Wellness is not just sort of doing a variety of activities to maintain work-life balance. It's actually considering that your mental health is just like if you were wanting to monitor your footsteps or your glucose, that you would be able to do this in the same way you would with any other aspects of your physical health. And so what we found amazing is that within the 1 week of deploying the symptom tracker to all our healthcare workers, we saw an increase in the use of our urgent counseling services. And it really suggested that people either were not aware of the level of their anxiety or depression, or that they, by using this sort of simple digital tool and hopefully making this attitudinal shift, that they engaged in our services. What was surprising to us was just the high levels of prevalence of trauma, anxiety, and depression. It was up to 30 to 40%, especially during the height of the pandemic. And this is just the last major data slide, but the first two panels are just sort of measures. The PHQ-9 is for depressive symptoms, GAD-7 is for anxiety symptoms, and all of last year, you see that there is these sort of a steady increase in the prevalence of this depression and anxiety among our healthcare workers. And I think there are two reasons for this. One is that essentially that it's very difficult to maintain one's sense of equanimity in the persistence of constant uncertainty, and that you have a toolbox that you use to basically make it through the day, but after 20 months, it's very difficult. And I think this is somewhat disturbing to us, that even when the cases were low in New York City, that the level of depression and anxiety continued to increase. But what I think the silver lining by doing this type of longitudinal study was that we found that the one thing that was probably the biggest predictor of anxiety and depression was actually social anxiety stress. It wasn't actually sort of whether the workers were on the front lines or the second line. It was actually whether or not when they went home, if there was someone there at home where they had some social support. And I think this also gets to sort of the point I made before, that the young adult brain in particular thrives on social reinforcement, and that the pandemic has created, unfortunately, probably the largest naturalistic stress experiment of social isolation potentially among our medical students and house officers. And so what I think what we have been trying to do is essentially show that we can use a mental health symptom tracker for our healthcare workers, provide urgent counseling. But I think in the future, we would also love to be able to integrate this cognitive behavioral therapy app to which I mentioned, because then you have this system where you can provide well-being related CBT for mild to moderate symptoms, and as the symptoms get worse, you can provide in-person urgent counseling. And I think this is sort of a stepped care model that we hope to be able to implement throughout all for all our healthcare workers at New York Presbyterian. I will, and I just want to end by saying that I think the future of trying to maintain wellness and well-being among our medical students and house officers and residents is to be able to provide not only an early warning system to a symptom tracker, but also a digital tool that will allow them to also be able to get sort of modules of cognitive behavioral therapy or other therapies in a digital manner that is asynchronous with actually seeing a therapist in person. And with that, I would just like to acknowledge everyone who did the work and be more than happy to take questions at this point. Thank you so much.
Thank you so much, Dr. Lee. As a resident and as a medical student not too long ago, everything you just so well explained is very relevant to what I'm going through right now. And, I guess I will say as a medical student, we study for step 1, then step 2. We're in the wards where, most of our time is done in the hospital or studying, and it can be very stressful, and time can be a very limited resource. And then in residency, it doesn't get any easier. Now, these days I'm working 70, 80 hours a week, and actually it's my job and responsibility to take care of patients. So at times it can be hard to find time not only to decompress, but also, the bulk of your talk was about cognitive behavioral therapy. So my question to you is, what do you recommend to medical students and residents who are listening to this talk about carving out time within such a busy workday schedule to perhaps pursue cognitive behavioral therapy if they need it? What do you recommend?
So I think that that's a great question. No one has probably the time as a medical student or a resident to do a full course, even with the Maya app, which I hope at some point to disseminate not just among Weill Cornell and New York Presbyterian medical students and residents, but to other medical schools and hospitals. But is that there are certain core principles of CBT, such as sort of mindfulness and maintaining routines. So I would say that at every moment that a medical student or resident has, in terms of trying to have certain routines that you have used in the past to maintain wellness and resilience, whether it be having dinner with friends at this point every Friday night, or even something even as simple as part of our CBT app, that even before you sort of sterilize your hands at the Purell dispenser, take 10 seconds just to take a couple deep breaths or something like that. It really is something. It sounds simple, but if you it's amazing just how if you can maintain certain routines, because you have to remember, before the pandemic, we all had routines with which to sort of try to maintain balance. But with the pandemic, we did many things that are so atypical of what we would normally do. And I think if we can get back to those routines, what you used to do, I think would be something I would highly recommend, especially maintaining contact with friends and relatives. I think the main takeaway from our longitudinal study we did is that social isolation seems to be the driving factor here. So do things that will actually force you to be with others when you're not in the workplace, or even in the workplace, make time to make sure you connect with your colleagues and peers in particular.
Thank you so much. And now I think we're going to go on to the next session, which is the abstract poster session, which I'll be moderating with Dr. Cecilia Yoon.
Hello again. So I think I'm going to be hosting probably one of the most fun parts of the convention, which is the scientific abstract competition poster session, where we get to hear about some of the impressive research work being done by medical students, residents, and fellows. So each speaker will have about 5 minutes to present their research abstracts, and time permitting, have some question and answers as well. So I will make the introductions for the first four speakers. And so to start with, it's going to be Esther Rowe, who is a fourth-year medical student at Mercer University School of Medicine. Then it will be Juliana E. Kim. She's a second-year medical student from Rutgers Robert Wood Johnson Medical School. And then Eric K. Kim, who's a fourth-year medical student from the University of California, San Francisco School of Medicine. And then Christine M. Park, who's a third-year, Dr. Christine Park, I should say, who's a third-year resident at Weill Cornell Medical College, Department of Internal Medicine. So we'll have Esther Rowe start first.
Hi, my name is Esther Rowe. So let me just share my screen. Okay, so the title of my presentation or my project was Ambient Air Emissions of Endocrine Disrupting Metals and the Incidence of Hormone Receptor Dependent Female Breast Cancer in the US. So basically in the introduction, we found out that a lot of breast cancer, which is the second leading cause of cancer death in women in the US, estrogen plays a really big role in the development. So we kind of wanted to look into the role that estrogen plays in converting precancer cells to cancer cells during tumor progression. And the role of the PR, the progesterone receptors, wasn't yet fully understood, but it was known that the gene expression of PR depends on the presence of estrogen, which is why we kind of decided to study this. So the long-term exposure to endocrine disrupting metals known as metalloestrogens can stimulate and have an affinity for hormone receptors in the absence of endogenous estrogen. So exposure to those metals can have long half-lives and accumulate toxic levels in breast tissue in women. And specifically, we looked at ambient air emissions of various metalloestrogens, but we looked at arsenic, cadmium, chromium, lead, and mercury. And then we looked at the incidence of hormone receptor dependent female breast cancer in the US by analyzing county level data from different regions. So in the methods, we specifically looked at the SEER program, and we received breast cancer incidence data from that program. And a total of 200 counties were looked at in 9 different regions, and those are listed in that section. And then the annual incidence for ER and PR receptor status was analyzed for specific years, as well as HER2 positive and HER2 negative for a different set of years. And then what we did was we looked at the metal emission data collected from National Emissions Inventory of the EPA, and then we looked at the metal concentrations for those specific metals I listed earlier. And we looked at 5.5 categories. So these are like point, non-point, and different types of resources or sources of emissions. And then we looked at the SEER program to analyze the average age-adjusted annual incidence rates of the different types of breast cancer for each county. So a linear regression analysis was used for that. And then the p-value of less than 0.05 was considered as statistically significant for this specific study. So in the results, you can kind of see in the table, I think it might look very small, but it's kind of bolded. And the values that are bolded, we found out that there's higher incidence rates of female breast cancer in more industrial regions specifically. So for instance, Seattle, San Francisco, Connecticut, Hawaii, and Atlanta as well. And then the lead emissions were the most significantly associated with ER positive, ER negative, PR negative, and HER2 negative breast cancers. And then arsenic was significantly associated with ER positive, ER negative, PR positive, and PR negative. And then you can also see it for cadmium emissions. They were only significantly associated with ER negative breast cancers, and then mercury was significantly associated with ER positive, ER negative, PR positive, PR negative, and HER2 negative breast cancers. And then for triple negative breast cancers, only lead and mercury were significantly associated. So at the end of the study, we kind of concluded that that the ecological data suggests that ambient exposures to certain metalloestrogens can have an impact on the pathogenesis of certain receptor breast cells cancers. And although we can say that they may be associated with the pathogenesis, it's limited because, again, it is an ecological study, which kind of prevents a causal relationship from being established. And then among all of the metals, mostly lead was the most significant one, and it displayed the strongest association with the most receptor status breast cancers overall. I think that's it for our presentation, our abstract that we have.
Thank you. And we'll have the next speaker, Juliana Kim.
All right, thank you so much. I will share my screen. I think, Esther, you need to stop sharing your screen for me to be able to share mine. Thank you. So my project that I'm presenting today is Institutional Factors Impacting Student Satisfaction on Medical School Response to COVID-19 Pandemic. As Dr. Lee talked about how COVID-19 disrupted a lot of our routines and schedules, and so this is kind of what we were interested in looking at. There have been multiple studies looking at how medical schools have adapted their in-person preclinical years to the COVID-19 pandemic, but we didn't really see much research in how clerkships and necessary in-person rotations were adjusted for this pandemic. So that's what we were investigating. This essentially what we did is we made a survey sent to different allopathic schools within the US, 10 total. And this survey had 5 different sections that looked at demographics, exposure to COVID-19, availability of PPE, access to testing, and communications from the school. We also surveyed overall satisfaction and had an optional free response section for the students to fill out. And so the primary outcome for our study was overall satisfaction regarding the medical schools' responses to the pandemic. And the secondary outcomes were the sections that I described, such as school communication, exposure to COVID, the PPE availability, and COVID-19 testing access. So in total, we had 430 respondents with a response rate of 13%. While more than half the students were satisfied, 61.9%, more than 1 in 5, 21.9%, were dissatisfied with their school's response. And what we found was that satisfaction with communication seemed to be the biggest indicator of overall satisfaction with their school, along with COVID-19 exposure minimization, COVID-19 testing access, and while satisfaction with PPE accessibility was not indicative of overall satisfaction. And so what we also found was that communication on PPE availability, number of COVID-19 cases, and supportive messages were also effective, while communication and testing protocols were not. So looking at this logistic regression model, that's the main method of an analysis that we did for our survey. We saw that the satisfied with school communication was the biggest indicator with an odds ratio of 69. So what was also interesting in our study, we found that demographic features weren't statistically significant when the other 4 parts of the survey were factored into the overall satisfaction model. That suggests that school, regardless of region or enrollment size, have the potential to adequately prepare their students for crises such as this pandemic. It also shows that students were satisfied with their exposure to COVID-19 patients, attended schools with clear policies for post-exposure quarantine. So seeing the communication aspect, both in terms of COVID exposure and testing protocols, were very indicative of overall satisfaction. Testing positively was actually not a predictive factor of satisfaction, which is surprising. As I said, what mattered most was what students, whether it was a clear policy in place as to what they should do with that exposure. Notably, also the free response corroborated the value of effective communication. So common responses were they wanted more frequent and more transparent updates, or they requested more student involvement in their schools' updates or protocols with COVID-19. So what our study discovered is that schools can best improve student satisfaction by prioritizing communication, which is a resource that all schools can utilize regardless of the physical resources that they have available. The increasing PPE availability and COVID-19 testing access and exposure are, again, limited resources available to schools depending on how much funding that they have. But again, communication seems to be the biggest thing that schools can focus on improving in light of this most recent pandemic. I want to also thank all of my collaborators on this project, and thank you so much for allowing me to present at this convention.
Thank you, Juliana. So next is going to be Eric Kim.
Hello everyone, my name is Eric Kim. I'm a medical student at University of California, San Francisco, currently on a research here, and I'm very excited to be here to share with you my presentation titled Exploratory Analysis of Abstracts on Health Disparities in Otology and Neurotology Conferences. So the NIH has defined health disparities as differences among specific populations in attaining health potential, and we know that these are a result of centuries of structural racism that unfortunately persists to this day. Within otolaryngology, research has started looking at this with one scoping review in laryngology identifying 51 articles of nearly 5,000 unique abstracts that were related to race, ethnicity, sex, gender, insurance status, geography, income, and education. That's about 1%. The gap that I will be addressing today is that there has not been an identification of trends in scholarly output related to health disparities at otology and neurotology conferences. For this purpose, I analyzed 520 abstracts that were accepted to American Otological Society, AOS, and American Neurotology Society, ANS, at 2018 through 2021 combined otolaryngology spring meetings. And these spring meetings are an annual conference comprising 9 academic societies where the latest research and technology are presented. The articles were included if they discussed one or more of these topics: race and ethnicity, income level, insurance status, language, geography, and research in low and middle income countries. Of the 520 abstracts, I identified 9 abstracts that were related to one of these topics. That's about 1.73%. If you look at the chart on the right, you will see that the top 3 topics were race, ethnicity, insurance, and geography, followed by language and social impact of hearing loss at 2. And the social impact of hearing loss referred to the impact of hearing loss on employment prospects as well as health literacy. One article looked at income, and another one was a global health project based in the Dominican Republic. Of note, all of these studies were retrospective in nature. In the 4-year trend, you will see that the number of abstracts started out at 1 in 2018, followed by 3, 2, then back at 3 in 2021. The articles that were identified were number 1 low in number and number 2 retrospective. This really shows that there's a limited scope of health disparities research within otolaryngology and also highlights a need for more diverse types of research. I believe that academia is in a very privileged position and can be a powerful agent of affecting change and fighting health disparities. And academic societies can take an active role in sponsoring various types of research that more directly engage with patient populations that are most heavily impacted by health disparities. And some of these examples may include quality improvement, implementation science, and community-based research. In conclusion, we discussed the low number of health disparities related abstracts and the 2 major otology and urology conferences, and these numbers have remained stagnant in the 4-year interval. Future efforts should focus on expanding the scope of health disparities research to include more of the stakeholders' voices so that hopefully within a combined shared decision-making research model, they can identify tangible solutions to combat health disparities and involve more community voices. These are my references, and I thank you for your time.
Thank you, Eric. And then finally, we have Dr. Christine Park.
Okay. Hi, everybody. I'm going to be talking about my study, which is called Parametric T1 Mapping for Quantitative Differentiation of Cardiac Metastasis and Thrombus on Cardiac MRI. So cardiac MRI briefly is widely used in various fields of cardiovascular disease. The main advantage of cardiac MRI is its potential for tissue characterization within structures in the heart. There are different protocols and sequences that we can do with cardiac MRI, which include T1, T2 mapping, perfusion, and delayed enhancement cardiac MRI. Delayed enhancement cardiac MRI, also known as late gadolinium enhancement, basically is a commonly used technique in cardiac MRI imaging, and it's based on the delayed contrast enhancement of tissues and structures. LGE, or late gadolinium enhancement, is classically used to identify cardiac thrombus based on the fact that thrombuses are avascular, and so there is an absence of contrast uptake. Alternatively, late gadolinium enhancement can also identify tumors within structures in the heart. And this is because, as you know, tumors are vascular, and so tumors enhance on LGE. And there's a lot of heterogeneity that can be seen due to regional variations in vascularity within tumors. So LGE is the standard reference to differentiate between cardiac tumor and cardiac thrombus. And it does this in a binary manner based on the presence or absence of contrast enhancement. So it essentially says, yes, there's contrast enhancement, this is likely a tumor, or no, there's absence of contrast enhancement, therefore making the mass more likely to be a thrombus. T1 mapping is a different protocol that we can use, and it's a quantitative tool that can measure the extent of enhancement in cardiac masses. Essentially, gadolinium contrast shortens T1, and therefore the more enhancement, the shorter the T1. This is pretty important because it has potential prognostication for patients with cardiac masses that are identified as tumors. It can essentially potentially quantify the amount of contrast enhancement, which would technically lead us to think that the tumor is much more vascular. So my project focused on cancer patients with cardiac masses, and we tried to identify whether or not pre and post contrast T1 mapping can accurately distinguish between cardiac neoplasms versus cardiac thrombus compared to the standard reference of late gadolinium enhancement. Our study sample comprised of patients with systemic malignancies at Memorial Sloan Kettering and NYP Cornell with known cardiac masses. The etiology of the cardiac mass was defined and classified by late gadolinium enhancement to be either neoplasm or cardiac metastasis or cardiac thrombus. T1 mapping was performed by clinicians to determine whether or not the cardiac mass was a metastasis or a thrombus, and this clinician was, of course, blinded to the late gadolinium enhancement results. Table 1 depicts our clinical characteristics of the sample study. We had a total of 94 patients. 81% of them had cardiac metastasis defined by late gadolinium enhancement, and 19% of them had cardiac thrombus defined by late gadolinium enhancement. The most common cancer etiologies were sarcoma and then GI, and then common cardiovascular morbidities were found to be hypertension, hyperlipidemia, and smoking status. Figure 1 shows our mean enhancement of the pre-contrast T1 and post-contrast T1 and extracellular volume T1, which is essentially a ratio between the two. You can see that cardiac metastasis actually had a longer pre-contrast T1 compared to a shorter post-contrast T1 when compared to cardiac thrombus. We're unsure why it's longer in the pre-contrast phase. It might have something to do with tissue properties, but definitely something to explore later on. We then constructed ROC curves to determine the optimal cutoff for the pre-contrast, post-contrast T1 and extracellular volume compared to the standard reference. We found that the pre-contrast T1 cutoff of 1,284 milliseconds yielded a 91% sensitivity, but a 56% specificity. However, the post-contrast T1 cutoff of 578 milliseconds yielded 91% and 88% sensitivity and specificity, respectively. And then finally, the extracellular volume cutoff of 22% yielded 100% sensitivity and 83% specificity. In conclusion, our results are promising and show that T1 mapping, including pre and post-contrast tissue characterization, can accurately distinguish between cardiac metastasis and cardiac thrombus. And then just briefly going over, why these results are potentially important. We had a patient who had a metastatic malignancy and was found to have a small cardiac tumor invading his anterior myocardium on cardiac MRI. And as you can see on the imaging, it's a very small initial tumor. But as this patient was followed through the years, we can see that this tumor is a very aggressive one that invades into the cardiac space. And so T1 mapping can hopefully quantify how much contrast enhancement there is, and therefore the vascularity of a tumor, and have important potential prognostication in these patients. Thank you.
Thank you so much. Thank you so much, everybody. So we have some time for some questions and questions for this four speakers before we go on to the next speakers. So I think there's a question for Esther, actually. So if you can have them all on. So the question is, did you try controlling for any factors like socioeconomic when examining metal impact on breast cancer risk, sorry.
We did adjust for socioeconomic status, but we did not adjust for specific races or anything like that. We did adjust for smoking and socioeconomic status.
And actually a follow-up question, Esther, from me. Do you think this can possibly explain some of the geographic clusters of breast cancers that we are seeing? Because it is an interesting kind of concept association.
I definitely do think that it can potentially be an explanation for geographical clusters, but again, I also think that maybe race could also play a part in it, because specific races might be more vulnerable to specific breast cancers according to receptor status. So I think it should be further studied.
Great, thank you. So I have a question for Juliana. So regarding the satisfaction from the medical students during the pandemic. So you mentioned communication as being one of the most important factors in student satisfaction. Do you think there's any specific details on the form of communication? Do you think a specific email from the deans, or more of a town hall, or who specifically giving the message? Kind of if there's any more elaboration on that.
Yeah, so in our free response, we allowed students kind of input what they suggested or what they liked or didn't like about their school's response. And it seemed like the biggest thing was that they wanted more student involvement and more frequent updates. There was one school that apparently told the students that they were kind of like overreacting. So I think they just want to feel listened to, whether that's the form of emails or town halls. I don't really know. There didn't seem to be like a preference per se, but I know a lot of schools did adapt frequent email updates in the schools, and the students seem to appreciate that.
Great, thank you. And I guess just as a student, do you specifically have any form of communication that you prefer? Is it social media, or is it directly email, you think, or?
Yeah, I think that I really appreciated receiving emails, like frequent emails kind of about the protocols and the changes in testing protocols and quarantine exposure. I think that was the biggest thing, is if you are exposed, students, even as preclinical students, we were kind of confused as to what that would mean. And so I know that that confusion was even more present with the clerkships. And I know, talking from upperclassmen, they didn't really know how that would affect their timing and their ability to complete their clerkships. So I believe that the frequent emails and also being receptive to student feedback and making the students feel heard would go a long way in times such as these.
Yeah, the stressful time. Exactly. Thank you. So I have a question for Eric as well. So do you think, what made you kind of interested in health disparities research in the subspecialties? Because you are correct, there's probably not as many. In internal medicine, we are seeing more and more. And so just kind of the drivers of your interest in this topic.
Thanks for that question. One of the main reasons why I came to medicine in the first place was my interest in immigrant health from my own personal experiences, and that kind of broadened out to health disparities research in general. And in terms of subspecialty, I was really kind of all over the place throughout my medical career, or medical school career. And I came upon otolaryngology and really enjoyed it, but I also realized that within the surgical subspecialties especially, the health disparities research is still very much in beginning phases. And I thought that this type of analysis of abstracts where the most exciting and the newest research is presented could be a good proxy for seeing where the field is at.
Great. And just a follow-up question regarding that. Regarding otology, what do you think some of the abstract researches out there that seem most promising or most interesting for you?
For me, I think hearing loss has been really interesting, and I think there has been a lot of work around that actually related to health disparities, although I think there's a lot of room to go in terms of hearing loss disparities research in low and middle income countries especially, as well as domestically with the more disadvantaged groups. Another interest of mine is vestibular disease, which is not something that's very frequently talked about within ENT, but it is extremely debilitating, and I think the impact of it has not been as well studied yet either.
Great, thank you so much. And a question for Christine actually came up. Can T1 mapping have therapeutic implications? I guess you showed one case it did, but anything else that you can elaborate on?
I think the importance of T1 mapping is the fact that it can quantify how vascular a tumor is, which could potentially tell us early on if the tumor is a rapidly growing one versus a slower growing one. And so the case that I brought up in the end of my presentation, I just wanted to highlight that, instead of possibly serially monitoring this patient with yearly imaging, he could have been offered radiation or even like palliative chemotherapy earlier on.
Okay, thank you so much. I think, I think that we have time for one more question, just to ask Christine. What are some of the downsides of the T1 mapping technology that you can foresee?
I'm not sure about any downsides. I think that it's still new, and obviously my study was smaller. It was only 94 patients, and so I think that there's like a lot of room for exploring like further patients and more patients with cardiac masses to distinguish between thrombus versus neoplasms.
Great, thank you so much. I really appreciate you staying for the question and answer and really some of the great research work that you're doing. So please continue. So we're going to have Justin come up for the next speakers.
All right, so for the next three speakers, I'm going to introduce, first of which is Christy Lee, who is a third-year medical student at the Medical College of Georgia. All right, looks like we're having some technical difficulties. Christy, I think, was muted. So I think for now we'll go on to the next speaker while we situate that. We'll go on to Joseph Hahn, who is a third-year medical student at the Icahn School of Medicine at Mount Sinai.
All right. Christy, do you mind letting me share the screen? Thank you. All right. All right. Hello, everyone. My name is Joseph Hahn. I am a medical student at Mount Sinai. I'm currently on a research year, and today I'll be talking about a new tool in the melanoma arsenal, evaluating the performance of electrical impedance spectroscopy. So to begin with, what is electrical impedance spectroscopy? It is a non-invasive point-of-care diagnostic tool to assist in melanoma detection. The EIS device, or called Nevasense, utilizes a low voltage to measure the electrical resistance of pigmented skin lesions, which differs between malignant and benign lesions. So how does EIS work? So when applying the device on a pigmented skin lesion, it outputs a score of 0 to 10, with 0 to 3 scores having a negative predictive value of 99%, being a melanoma, whereas scores of 4 to 10 having an increased positive predictive value of 9% to 64% the higher you go. So why do we do this study? So we wanted to see how EIS compares to dermoscopy, which is a standard practice when evaluating pigmented skin lesions. Because it is critical to accurately identify concerning pigmented skin lesion for biopsy, while avoiding biopsies for benign lesions. So our study was a survey study of 89 respondents. We had 38 practicing dermatologists, 25 dermatology residents, and 26 medical students. All respondents were presented 24 randomly selected histologically confirmed images of pigmented skin lesions, 8 being melanomas, 8 dysplastic nevi, and 8 melanocytic nevi. 12 of these lesions, so 4 from each diagnosis group, were randomly selected to be presented as a clinical image with associated dermoscopic image. So we had this in the dermoscopy group. While the other 12 lesions were presented as a clinical image with a corresponding EIS score. So on the left, you'll see a clinical image right here. And below we have a dermoscopic image. And on the right, we have a clinical image, and on the below, we have EIS, basically what the EIS would output. So for each clinical image, they were presented either or. And then they were followed up with a question on a scale of 1 to 5, with 1 being not necessary and 5 being extremely necessary. How necessary is a biopsy in this case? We considered any score of 1 to 3 to be considered a decision not to biopsy, whereas 4 to 5 being considered a decision to biopsy. And then we asked, what did you expect the pathology result to be? Melanocytic nevus, dysplastic nevus, or a melanoma? So the results, we had a total of 1,740 clinical biopsy decisions of the total 89 respondents, 862 in the dermoscopy group and 878 in the EIS group. And with dermoscopy, we saw that 62.8% of lesions were selected for biopsy, whereas with EIS, 48.1% of lesions were selected for biopsy. So here's a table of comparing the dermoscopy and EIS sensitivities and specificities. And we see here the EIS sensitivity was significantly greater of 75% compared to 66% with dermoscopy. The specificity was similarly significantly increased of 70% of EIS compared to 40% of dermoscopy. And stratifying based on training level, we see that dermatologists actually had a similar sensitivity percentage of 81% for both, but dermatology residents and medical students both saw an increased sensitivity rate for EIS compared to dermoscopy. Specificity, however, on the other hand, had across all boards saw a significant increase in specificity for EIS compared to dermoscopy. So conclusions, this study suggests that EIS positively impacts the accuracy of biopsy decisions for pigmented skin lesions when compared to dermoscopy, especially those with lower self-rated dermoscopy proficiency. And so EIS may complement in the future dermoscopy by helping a broader range of providers make improved diagnostic decisions by increasing the malignant pigmented skin lesion detection and reducing unnecessary biopsies. So thank you very much for listening to my presentation.
All right, so we'll go back to Christy Lee. Christy?
Can you guys hear me now? Is the mic working? Okay, okay. All right.
Yes, it's working.
All right, perfect. Okay. All right, so my research was on exosome biopsy for acute kidney injury. Well, kidneys are great because when one fails, the other works extra hard until it gives in. And kidney is also one of the first organs to be sacrificed. And nonetheless, they're crucial, and we want to prevent all AKIs and AKIs becoming ESRD patients. However, our lab had a different outlook and focus on the recovery instead of the injury. And that way, ICU beds can be freed and we can allocate resources appropriately, which can be cost effective for the hospital and better for the patients. So then our lab wanted to study the most accurate, yet least costly and invasive methods of predicting kidney recovered and thought urinary exosomes can be a potential biomarker. We extracted urine from controlled and injured kidney rats at different times. We isolated RNA from collected urinary exosome using RT-PCR techniques. Well, we discovered several sequences to be potential candidates, and they were further confirmed with RT-qPCR. And to optimize the reaction conditions, 3 methods were compared, and the most optimal protocol was method 3, as you can see in the poster, and it had the relative CQ of controlled RNA, which proved that to be correct.
Thank you, Christy. All right, so our next speaker was not able to make it, Dr. Jason Han. He's feeling under the weather. So we're going to go on to our last speaker for this session, who's Dr. John Yang. He is a second-year medicine resident at the Icahn School of Medicine at Mount Sinai in New York City.
Can everyone hear me?
Yes.
Okay, great. Today I'll be discussing the racial and ethnic geographic differences in the incidence of gastroesophageal cancers in the US. There. Okay. So as we heard from Drs. Huang and Dr. Hurd, like gastroesophageal cancers are among the most common and deadly cancers worldwide. In fact, gastric cancer is the 5th most common and 3rd leading cause of cancer death, whereas the esophageal cancer accounts for 7th most common and 6th leading cause of cancer death in the world. And more, the US is becoming more diverse than ever, with fast-growing Asian Americans and Hispanics, and thus so are our patients we see every day. And however, racial and ethnic differences in the incidence of gastroesophageal cancers exist in the US. And while we know many of the risk factors, such as male sex, race, ethnicity, H. pylori infection, hereditary cancer status, we have not yet characterized the geographic distribution in the US, which we believe could provide insight into reduction of gastroesophageal cancers. And so we used surveillance epidemiology and end result registry, also known as SEER. This is a US National Cancer Registry, and we identified primary gastroesophageal cancers with confirmed malignant behavior using 3rd edition of International Classification of Diseases for Oncology Codes. Using SEER-STAT and Joint Point Regression Program, which are softwares developed by the National Cancer Institute, we estimated the incidence rates and calculated annual percent changes. And so here we have a table of age-adjusted incidence rates and annual percent changes of gastroesophageal cancers, stratified by the demographics in the left column and by US Census Bureau regions at the top. And so first I want to jump down here. We found that across all regions, the Northeast, West, Midwest, and South, we found that incidence rates of distant gastric esophageal cancers were greater than those for local or regional disease, indicating that most patients are being diagnosed at an advanced stage. And this is a huge contrast to the current experience where the majority are being diagnosed at a localized stage. And comparing the changes in gastroesophageal cancers incidence rates over this time period, the West and South showed the largest and the smallest annual percent changes, respectively. I'll get to that. Overall, gastroesophageal cancers have decreased incidence rates over time across all regions. And this trend, when stratified, was also seen in non-cardiac gastric cancer, whereas trends in gastric cardia and esophageal cancers showed varying annual percent changes in incidence rates by geography. The incidence rate was the highest in the Northeast, 14.4 per 100,000 person years. compared to other regions. So here you can see in the red line at the top, separated from the pack on this graph, and it's a stark contrast. And this geographic variation in incidence rates is also found in other cancers, such as colorectal cancers and esophageal cancer. So, while these differences may be explained by race and ethnicities and their geographic distribution across the US, we're learning that differing incidence rates can be influenced by a complex host of factors related to diet, as we learned earlier on this convention, immigration, access to healthcare, preventative care. And so bottom line is further work is needed in elucidating this trend. And across all regions, the incidence rates increased by approximately 10, 20, 40-fold in those diagnosed between ages 50s, 60s, or 70s or above, respectively, when compared to those diagnosed before the age of 50. And this gives us an idea of when we should screen our patients. And just to round up, the incidence rates of men were twice those of women across all regions, which is consistent with prior studies. And another important finding is that all racial and ethnic minority groups had higher incidence rates versus the non-Hispanic whites across all regions, as seen on this figure. So the blue line representing the non-Hispanic whites have much lower incidence rates compared to other race and ethnicities seen above. And so, and finally, this is a table, same table with different demographics on the left, and across all regions, again, areas with greater than 15% of the population below the poverty line or poor areas experience significantly higher incidence rates than more affluent areas, which is very interesting. And so in conclusion, we found that gastric and esophageal cancers incidence rates are highest among men of non-white racial ethnic groups in the Northeast. Further work is obviously needed to explain these differences, especially the geographic variation of incidence rates to address potential disparities in screening and resource allocation for the highest risk population. And I'd like to finally add that this has been a really great opportunity to highlight the theme of this year's convention. I think promoting diversity and international collaboration to drive innovation. I mean, we have a lot to learn from the Korean experience and a lot of work to do on our end. So thank you for your time. I want to thank Dr. Michelle Kim for her mentorship and introducing me to KAMA and this convention. Thank you.
All right, thank you to all the speakers. You can tell that you all put in a lot of work, and those are very nice talks. Now we'll do a brief Q&A session, so if we can have everyone's faces on the screen. Okay, so we'll start with Christy. Christy, I know you're a medical student, and maybe you haven't had the experience of being in as much clinic or inpatient time as some of the other folks, but how do you see this exosome-based liquid biopsy being used in a clinical setting? Do you see it being used in the hospital, in clinic, or on an outpatient basis, inpatient basis? How do you see this potentially being utilized?
Well, if we can get this to be worked, that would be awesome because, urine sample is so easy to obtain, and once obtained, and if it can provide the information that I've just discussed, then it's like cost effective, it's safe, it's not invasive. The patient can easily provide the sample and so that we can look at it. I think it would be great. It's just right now it's in the process and we're still working to see if the RNA sequence that we found is actually a biomarker and that it's not, and that it's sensitive and specific enough to be used in a clinical setting.
Thank you. And then we'll go on to Joseph. We have a question from the chat. Joseph, what's the standard cost of cost comparison of dermoscopy versus the EIS approach from both a manufacturing perspective and an operation standpoint?
Sure. So thank you for the question. So first, Nevisense, their EIS device cost around $2,000. So it's an investment for any provider to include in their practice. Manufacturing, I think that might be proprietary. I don't really know how much it would cost, but it costs about $2,000, I believe, to purchase. And a dermatoscope, on the dermatoscope side, you can find a dermatoscope for hundreds of dollars. They can even go for above $1,000, even above $2,000 range. It's a pretty wide variety for the cost of the dermatoscopes. So, I mean, when you compare that to an EIS device, it could be pretty similar. There's just more variety, there's just more ranges in the price range for dermatoscopes.
Thank you. Another question I want to ask is, what was your study's decision making on including dermatologists, residents, and students?
Sure. Like the rationale behind including all three, we just wanted to see kind of how the different levels of training would impact, I guess, one's decision to biopsy based on dermatoscope image or dermoscopy image or EIS, and how they would use an how they would lean on more of an EIS score or versus their dermoscopy expertise. And we saw that for more trained people, like the dermatologists, their sensitivity for dermoscopy was actually very similar, probably because they're very experienced. And then we saw that the residents and the medical students saw more improvement with the EIS.
Thank you. And then, John, do you have any thoughts on possible interventions to improve screening in these at-risk populations?
Yeah, thank you for the question. Yeah, I mean, we have a lot of work to do, right? I think if anybody joined, conference earlier, I think Dr. Chua Huang and Chin He have both kind of highlighted this. I think, practically it's getting to the USPSTF at the end of the day and trying to get their support. The research is out there. We have the evidence. I think as soon as we were able to get their support and get the primary care folks to really recommend, say upper endoscopy screening, similar to the colonoscopy screening, I think that's one way. But also these research that we're doing are really being done to identify high risk population, right? So, as we've learned from the California registry where they had disaggregated, Asian American population, we saw strikingly the Koreans had really much higher incidence rates of gastric cancer incidence compared to anyone else. And I think that alone is so telling that, when you're putting this in a clinical scenario and bringing this to your own clinic, I mean, when you see those patients, when you see those Koreans and other Asian Americans, and also really any minority groups or anyone who immigrated from those regions, we should really be proactive in getting them a screening of some sort.
Thank you. And then another question I have for you, John, is, you lightly touched on, further work or study into explaining the demographic differences in incidence of this type of cancer. What would you hang your hat on as maybe the one or two factors that you think are most contributory, or do you think it's not that simple and it's more nuanced than that?
Yeah, so you're touching on the geographical variation of incidence. And so it's definitely more nuanced than just one or two things, obviously. But, recently, the past few years, we're finding out that esophageal cancers are somehow has increased incidence in certain areas in the North or Midwest area. And similar to colorectal cancer too, somehow in the Midwest, there's a higher incidence rates there. And we're trying to figure out there's definitely more than just the typical risk factors that we know about, the H. pylori status and your history of cancer. There's definitely a social aspect. There's definitely, immigration status. That's another thing that is not being included in these registries, so it's very hard to conduct research there. I think acculturation, right? So if somebody has immigrated to a different region, do they acculturate to change their diet from eating kimchi and 된장찌개 to eating like burgers and McDonald's? Like it's different in that sense, like it's I think it's definitely more nuanced, and it's going to be a huge challenge to tackle that.
Agree, and I'm sure similar. Well, it'll be interesting to see how this could be applied to other types of cancer, like lung cancer, breast cancer, and things like that. So yeah, it's very, very interesting talk. All right, so we're a little ahead of schedule, but I think now we can move on to the award ceremony for these excellent talks.
Yes, thank you to all the 7 presenters who are really excellent, and really hope you continue this excellent research as well. It's been very impressive. So it's my pleasure to actually go on to the next part of the talk, the scientific abstract competition presentations and award ceremony for the top 3 abstracts. I'm going to have Dr. Ji-won Kim kind of moderate and announce the 3rd place.
Wonderful. Thank you, Cecilia. Congratulations again to all of the students and residents, really fantastic talks. So we'll move on to the top 3 the top 3 abstract presentations. We'll start with our 3rd place abstract presenter, who is Gina Lee. Gina Lee is a 2nd-year medical student at Georgetown University. Her talk is titled Patient-Reported Functional Outcomes in Below-Knee Amputees versus Partial Foot Amputees. And we will take some questions after this talk.
Okay, well, thank you so much, Dr. Kim, for that introduction. And I am so grateful and honored to be here. So thank you so much, Kama, for providing me this chance to present my presentation. So today I'll be talking to all of you on my topic titled Measuring Patient-Centered Outcome Measures in Partial Foot Amputation and Below-the-Knee Amputation Patient at Tertiary Limb Salvage Center. So throughout my presentation, I'm going to be comparing the functional outcomes of 2 main lower extremity amputation techniques, the partial foot amputation, abbreviated PFA, and below the knee amputation, abbreviated BKA, and I'll be using the PFA and BKA abbreviations throughout my presentation. So I'll just briefly explain both of them. So the PFA, just is amputation of the foot, and this illustration here shows you the 4 different amputation techniques that we looked at, the Ray, transmetatarsal, Lisfranc, and Chopart. And I'm not going to go into details for these amputation techniques because that's not necessary for the presentation. For the BKA, that was defined as amputation between tibial tubercle and junction of the middle and distal thirds of the tibia. And the benefit of a PFA is that it does allow patients to maintain their maximal limb length. It allows for maximum rehabilitation, lower energy expenditure. And a benefit of a BKA, or times when BKA would perform over a PFA, is if there's a risk of vascular insufficiency or infection with a PFA. The downside of a PFA is that it is prone to skin breakdowns, which could lead to more infection and poor wound healing, which would be very costly and painful for the patient. Downside of a BKA is that it does require more energy expenditure from the perspective of the patient after the amputation, just because more of the limb is amputated. So what we wanted to do at our wound clinics was we wanted to compare the functional outcomes of these 2 amputation techniques using the perspective of patients. So we used a patient-reported outcome measure study. So what is a patient-reported outcome measure, or PROM for short? So PROM is a standardized self-report measure assessing the health and quality of life of patients. So basically, it's just a way for patients to communicate to their physicians how a surgery impacted their quality of life. And PROM studies are very important. They have been correlated with enhancing a patient's quality of life and improving communication between the physician and the patient. And unfortunately, there is a current lack of PROM studies on lower extremity chronic wound patients. The few PROM studies that have been conducted on PFA and BKA patients have reported there to be no significant difference in functionality between these 2 groups. And these studies also did not compare the lower extremity mobility of these patients over time. So what we wanted to do at our wound clinic was we wanted to determine if the partial foot amputation and below the knee amputation patients report any differences in their ability to ambulate and function at less than a year versus more than a year since their amputation. So next I'll talk about the methods of our study. So from June 11th to July 30th, myself and another medical student, we administered PROM surveys to 512 patients all over the age of 18, Center for Wound Healing at SR Georgetown Hospital. This was a very time-intensive process. We came into the clinic almost every day throughout the week, stayed there for 8 hours surveying the patients. The patients took the survey to the Tonic Health app on in-clinic iPads or on paper. There were a total of 4 surveys the patients took. The first survey was a lower extremity function mobility survey, and I'll be referring to this survey as a mobility survey throughout my presentation. So this chart here outlines the scoring system of the survey. The survey asked the patients 19 questions to assess their ability to carry out various activities involving the trunk, ambulation, balance, or endurance, and each question is assigned a score range from 1 to 5, 5 indicating that the patient had no difficulty performing the activity, 1 indicating the patient couldn't do the activity at all. The total score ranged from 19 to 95, with 19 indicating the lowest functionality and 95 indicating the highest functionality. So higher the mobility survey score, the more functional the participant is. And we only analyzed the survey results of patients who completed all 19 questions on the survey. There were 3 other surveys that assessed the patient's pain level and the extent to which pain interfered with their quality of life, but I'll just be focusing on the functional mobility survey scores for today. And a retrospective chart review was conducted to obtain information regarding the patient's demographics, surgical history to stratify the patients into groups depending on the time since their operation. And as for statistical analysis, we used the ANOVA and t-test as applicable, and significance was determined to be a p-value of less than 0.05. So here are some images, sample questions from the mobility survey that was used. So one of the sample questions was, are you able to get on and off the toilet? And then the patient would just click on the answer that corresponded to that question. Another possible question was, are you able to step up and down curves? Are you able to get in and out of a car? So the results of my project are that this table here details the demographics of the 2 groups of patients in the study. So there were 47 PFA patients, 34 BKA patients. Their average age were around 60. There were more males than females, and as the chief comorbidity index was 5 for both groups. Around 58.9 months had passed since their operation when the BKA patients took the survey, and 23.3 months had passed since the PFA patients took the survey. And then the next table here shows that most of the PFA and the BKA patients were able to complete all of the questions on the mobility survey. So this is a table with the average mobility survey score for the PFA and the BKA patients who took the survey less than a year of their amputation. So standard deviation is in parentheses. The data suggests that the PFA patients had a higher mobility, lower mobility survey score than the BKA patients. And just as a reminder, the higher the survey score, higher the mobility survey score, the more functional the participant is. And it's a similar table, just comparing the patients more than a year since their amputation. And you can see that the PFA patients had a comparable mobility compared to the BKA patients. And overall, the data suggests that the PFA patients had comparable lower mobility survey scores to the BKA patients. And as indicated by the p-value, that the data is trending towards significance. So what do all these results mean? The PFA patients were trending towards a higher functionality and mobility compared to the BKA patients at less than a year since their surgery. And this was expected since PFA is a more conservative surgery. But what was surprising to us was that at more than a year since surgery, the data suggests that the 2 groups of patients had comparable functionality. And this was a case overall as well. So our preliminary results suggest that both the BKA and the PFA patients, they perceive their ability to function using their lower limbs and also to ambulate at similar levels, despite a presumed reduction in functionality and higher level of amputation, such as the BKA. So we suggest that this is very applicable in cases when physicians are contemplating conducting a PFA or a BKA on a patient. We also noted that both PFA and the BKA patients reported their functional mobility to improve over time. It's very promising for us since this just meant that we're helping our patients to improve. So limitations of our study are that we didn't take into account the various factors that contribute to functionality like pain, limb strength, prosthetic function, but we hope to in the future. And also some of our patients couldn't complete the survey on their own. They needed help filling out the survey. There's a possibility that the surveys just ask questions that weren't specific enough to their amputation. And next steps for us are to analyze the potential other causes of decreased functionality like pain. So we're planning to compare the PFA and the BKA patients in terms of their pain intensity and pain interference scores from the data we've already collected. And finally, we're also planning on analyzing longitudinal data from patients who completed the surveys more than once to monitor their functionality scores over time. And so in conclusion, I'd just like to state the main findings of our study. So our preliminary results suggest that within a year since surgery, the PFA patients had higher level of functionality than the BKA patients, but more than a year since surgery, these two groups showed comparable functionality. And overall, both the PFA and the BKA groups, they reported similar levels of ability to function and ambulate using their lower extremities. And the significance of our study is that this is the first study that we know of to compare the lower extremity mobility of the PFA and the BKA patients over time. And this is important because there's still a lack of PROM studies within these patient groups. And PROM studies are a very quick, effective way to gain firsthand account of qualitative outcomes of patients. So continuation of PROM studies like this, we hope that these results can assist in the shared decision-making process between patients and surgeons by providing data regarding comparable patient-perceived outcomes between these two procedures. So I'd just like to end by acknowledging the funding that I received from our school summer fellowship, Dr. Evans, Dr. Fan, Dr. Attinger, all of our research fellows who really helped me with the presentation and with my first clinical research project, and all of the MedStar Georgetown Center for Wound Healing staff as well. So thank you so much. Thank you for your attention.
Great, thank you very much, Gina. So wonderful talk. And really interesting. You know, I have a couple of questions. You know, my first question has to do with the outcomes that you looked at. So I think it's fantastic that the functionality between the BK and the PFA groups were similar after the 1 year mark. Did you also consider or look at morbidity sort of related to the two procedures? Did one have higher morbidity or sort of worse outcomes? Whether it's immediately post-surgery or sort of long-term outcomes?
Yeah, it's a really good question. We didn't look at the mortality or morbidity, but we did look at pain. And we did a survey to assess their pain after the surgery, and we have those results. I just wasn't able to present them today. But the PFA patients actually reported a lower level of pain than the BKA patients, which was, I think, the only significant difference that we saw. But it was just really interesting, the functionality just didn't change between the two patient groups.
That's very interesting. And then what do you think happens at that 1 year mark where the two groups become more comparable? Is it something related to the procedure itself or the recovery? What are your thoughts on that trend sort of changing at that 1 year mark?
Yeah, that's also a really good question. So my hypothesis is that just by talking to the patients themselves when I was doing the survey, just their physical therapy that's involved in helping the patients to adjust to their prosthetics. It's like a time-intensive process, but the BK patients actually, they had more frequent visits to their physical therapist. So it might be that they just were able to gain more functionality using their prosthetics. And also, I think another difference is that the baseline pain and functionality of the BK patients was lower. I don't have data to support that, but just by talking to the patients, their functionality before the surgery was was worse compared to the PFA patients. So I think that just by getting that prosthetic, like not having that pain in their knee or having that infection anymore, being able to have at least a prosthetic to walk around for the BKA patients really improved their lives and improved their ability to function and walk around. And for the PFA patients, possible that just because like the amputation was just was relatively minimal compared to the BKA patients, it's possible that the PFA patients, they didn't report as much as of a strong difference in their functionality from their baseline to after they had their surgery. So I think that might be a reason why their functionality levels were comparable between the two groups.
Great, very interesting. And then, my last question had to do with, your findings are very promising, and I wanted to get your take in terms of the outlook for PFA. Do you foresee, PFAs sort of replacing BKAs? Do you foresee PFAs, in wider groups of patient populations? Based on your data, what are your thoughts in terms of, the future of PFA?
I think this is very promising for PFA. It's almost looking like PFA could be an alternative to BKA. Of course, the case would depend on the person, their chief comorbidity index, like their baseline function. But I think overall, based on our data, since after a year of surgery, since both groups do report comparable functionality, I think that this is that PFA could possibly replace BKA, and physicians can now well, I don't want to say that PFA can replace BKA because it just really depends on the patient's injury. But I think that when a physician is deciding whether to give a patient a PFA or a BKA, instead of worrying about the quality of life of the patients after the surgery, they can start just thinking about what's the rate of infection after the surgery, how are like the length of recovery of these patients, and so they can kind of focus on like the rate of recovery in terms of like it's going to be like less infection instead of focusing on just the quality of life of the patients.
Wonderful. Thank you so much, Gina, for your wonderful presentation. And thank you again for joining us, and congratulations.
Thank you.
So we'll move on to our second place awardee for the abstract presentation is Christopher Lowe. Christopher is a third-year medical student at Brown. His talk is titled Comparing FA and OCTA of Murine Eyes with DR with CLAHE and Gaussian kernel image processing technique. Welcome, Christopher.
Thanks for inviting me. Can you see my presentation slides?
Yes.
Okay. So, hello, I'm Christopher Lowe, a third-year med student at Brown University, as Dr. Kim has introduced. I'm very honored to get invited to give a presentation at CALMA Scientific Convention. And this is a project that I pursued through a Cole Scholarship at UC Davis during summer 2020. And I worked with my mentor, Dr. Susanna Park, who's an ophthalmologist over there. The title of this project is Comparing the Retinal Vascular Density on Fluorescein Angiography and OCT angiography in the mouse eyes with diabetic retinopathy using the contrast-limited adaptive histogram equalization and match filter imaging processing techniques. So to give you some background, there are two imaging modalities, FA and OCTA, often used in ophthalmology practice. But fluorescein angiography remains the gold standard used to evaluate the retinal vasculature, and about 1 million studies are performed annually in the United States. Although fluorescein angiography reveals details of microvasculature of retina, it still requires an intravenous injection and a skilled photographer. And it is time-consuming and have lower resolution compared to OCTA. And sometimes the fluorescein dye injected can cause side effects such as nausea or vomiting to a patient, and it can be challenging to find venous access for injection. On the other hand, the OCT angiography, which I'm going to call as OCTA, is a newer imaging technique developed to evaluate the retinal blood flow in the early 1990s. It is non-invasive and does not require any usage of dye and have higher resolution. It's rapidly becoming an indispensable imaging tool in evaluating patients with retinal vascular disease. And retinal vascular information obtained using either through FA and OCTA are similar. However, it's not always the same in human patients. In preclinical animal research, OCT angiography is starting to be used, but there is limited information regarding the relative sensitivity of fluorescein angiography versus OCTA in detecting retinal vascular flow in animals. So at UC Davis, we're fortunate to have this iPod retinal imaging facility for small animals equipped to obtain both FA and OCTA images simultaneously in mice. And the left picture shows a custom-made retinal imaging tool, which is capable of taking both FA and OCTA images on mice on anesthesia. The right picture shows how FA and OCTA image being captured simultaneously. The purpose of this study was to evaluate whether the retinal vascular density in the eyes of mouse with diabetic retinopathy using FA is comparable to those observed using OCTA. So the first method we used was we reviewed the whole FA and OCTA images obtained in mice with diabetic retinopathy from prior studies. And the mice had a streptozotocin-induced type 1 diabetes, and they developed a retinopathy by 6 months after induction of diabetes. And I used ImageJ analysis with Vessel plugin, this program, to measure the retinal vascular density in FA and OCTA. And as you can see in the images below, these two images are pretty much identical to the naked eye. But when I analyzed the vascular density of both FA and OCTA, the 14 paired images of two modalities with mouse eyes with diabetic retinopathy actually didn't correlate that much. They showed no significant correlation at all, having the correlation of R.08 and p-value of 0.78. So we need another method to compare these two imaging modalities. So the next thing we tried was, since some of the areas of the image did not appear in complete focus, we evaluated the retinal vascular density of the region of the retina and the highest resolution on both FA and OCTA images. But this was not based on any numerical cutoff, but it has inherent bias since this high resolution areas was subjectively selected according to the observers. When analysis was limited to the selected area of the image with optimal image resolution on FA and OCTA, the vascular density were similar between two modalities. As you can see on the images on the left, the selected area of FA and OCTA were comparable. Out of the 14 pairs, the correlation value was 0.49 and p-value of 0.01. But the downside of this was the average selected areas with optimal resolution was only 4.5% of the total imaged area, ranging from 1.3 to 15.5%, which is definitely not representative of the whole imaged retina. So we weren't satisfied with these two methods of vascular analysis and had to come up with a new method to improve the image quality without introducing any bias. And with the help of Dr. Zawadzki, who's a visual imaging scientist at UC Davis, we used this method called contrast-limited adaptive histogram to improve the background vessel contrast and 2D match filtering technique to enhance both thick and thin vessels of the images. To give a brief background, the adaptive histogram equalization is a computer imaging processing techniques used to improve the contrast in the images, and it computes the several histograms of the images, and each corresponding to a distinct section of the image, and they use them to redistribute the light values of the image. And this method is suitable for improving the local contrast and enhancing the definition of the blurred images in the region of the image. And the match filtering technique is a linear filtering device which was originally developed for signal detection and a radar. And long story short, it basically maximizes a signal to noise ratio, which means they damp down the noises and the images. And with this improved imaging methods, we could definitely see a enhanced contrast of both FA and OCTA retinal vasculature on the bottom of the image compared to the top images on the raw images of the FA and OCTA. So a total of 50 degrees of retina were analyzed for retinal vascular density on FA and OCTA. And with this new method, when analysis was performed on enhanced images using the clay and two-dimensional match filter techniques, the vascular density on FA and OCTA images significantly correlated with correlation value of 0.74 and p-value of 0.002, even with the total image retina, not just part of the high-resolution areas. So in conclusion, the retinal vascular density in FA and OCT angiography does not correlate well with the raw images in the mouse eyes with the diabetic retinopathy. Secondly, retinal vascular density in FA and OCTA was comparable when optimal image resolution was obtained only in the limited area of the total retinal image, but that comprised only 4.5% of the total image area and had an inherent selection bias from the observers. Lastly, the retinal vascular density obtained using fluorescein angiography correlated well with that of the OCTA if we apply the contrast-limited adaptive histogram equalization and 2D match filtering techniques. And this was first studied to show how FA and OCTA vascular density measurement is comparable in animal model and corroborated potential use of OCT angiography in clinical practice for retinal disease and ophthalmology. But still, the project was a preliminary study to evaluate the comparability of FA and OCTA in retinal vascular analysis. And this study was limited in several ways. I'll say the study had only 14 pair of images totaling 28, which are relatively few number to be statistically meaningful, and focusing more on a smaller blood vessels, such as like capillaries, by excluding the main large vessels. And the retina could have yielded a relevant information on microvascular changes, which is often seen in a lot of like retinal pathologies like diabetic retinopathy. So those are the things that we could think of for the future studies if we are going to conduct from here. So that's pretty much all. I just want to thank all the CAMA and CAMSA and all the audiences here. I'm very honored to receive an award in scientific abstract competition today. I also want to thank my mentor, Dr. Susanna Park, who served as my research mentor for this project, and whole UC Davis Eye Center for supporting me through the Cole Scholarship Award. And thanks to the iPod retinal imaging team who has delivered me this awesome images of the retina of the mouse, and also taught me how to use a new techniques to improve and enhance the images for vascular analysis.
Wonderful. Thank you very much for that. It's a very, very interesting topic. A few questions for you, Christopher. So my first question has to do with OCT, the technique itself. It sounds like OCT is an emerging technique. It doesn't require contrast. And so if it could be performed in place of FA, that could be beneficial for patient care. Based on your findings, do you foresee or predict that OCTA could replace FA in the future? Do you think if that's the case, is it for particular patients with diabetic retinopathy that that OCTA might be most applicable for? What are your thoughts there?
So I think OCT angiography is definitely a more advanced technique compared to fluorescein angiography because it's more suitable. It can not only perform a qualitative analysis of how the vasculature of the retina looks like, but it can also perform a quantitative analysis of retinal vessels. And I think there's a whole lot of research going on how the retinal vasculature actually change in different like retinal pathologies like diabetic retinopathy, macular degeneration, sometimes central serous choroidal retinopathy. So since, as you've said, it's non-invasive, it takes faster and patients are more feel more comfortable with it, I feel like eventually it might replace the fluorescein angiography. And on top of that, since we can actually measure how the blood flow is looking like in different pathologies, I think they will give more information that is helpful in diagnosing and also like doing research about how those quantitative changes can actually happen in different retinal pathologies.
Very interesting. And a follow-up question related to that is, what are some of the barriers that currently exist? Is it a knowledge gap that exists? Is it a technical limitation? Does it need further optimization? What are some barriers to OCTA becoming more mainstream?
So I think definitely, so OCT angiography, although it was first developed in 1990s, I think it was introduced in 2014 in clinical practice. So definitely it hasn't been that long since it was introduced in patient practice. So I guess a lot of like ophthalmologists or all the health professionals are not used to this new technology. I think that could be one barrier, but also the cost. I think I heard it's quite expensive to get implemented, because even with the OCT angiography, I think we're not like sure how to use this OCTA wisely to actually make the investment worth it. So for now, we're just like comparing how OCT angiography can yield at least same or better information compared to fluorescein angiography, but we're not like able to use how this new like quantitative imaging can be actually translated to patient care. So a lot of research has to be done before we actually introduce the new imaging devices to have more effective outcomes, I think.
That makes a lot of sense. And then related to that, what do you think, do you foresee your findings being applicable to, in a clinical setting? So taking the model in animals and applying it to humans, do you think that your findings will be similar in a human cohort as well?
Yeah, I think so. I don't find any reason why it would not be too similar to what I've got in the mouse eyes with diabetic retinopathy. Like if I would have a chance, I would definitely first start with the human patients, especially with the patients with diabetic retinopathy. And since there's a lot of like overlap between mouse eyes and human eyes, I don't see any like reasonable reasons why it wouldn't be too different so far.
Makes sense. We look forward to hearing more about this. Very, very interesting topic. Wonderful. Thank you again, Christopher. So I'll give the floor back to Cecilia Yoon, who will be announcing the first place winner.
Yes, it's a difficult decision as always, since we've had so many excellent research abstracts submitted. And it is my pleasure to introduce the first place awardee. He happens to be a student in Korea, and we happen to be in Korea giving the convention, so it's all by coincidence. So the student is a second-year medical student at Yonsei University College of Medicine. His name is Sung-Won Burm. He will be talking, the title of his talk is Thoracic Muscle Mass Predicts Bone Gain After Parathyroidectomy in Primary Hyperparathyroidism. So thank you.
Hi, my name is Sung-Won Burm, and I am a second grade in Yonsei University College of Medicine. First, I want to thank the organizers of the Korean American Medical Association for giving me this wonderful opportunity to present our work in this conference. Our team investigated whether preoperative thoracic muscle mass predicts bone gain after parathyroidectomy in primary hyperparathyroidism. how can I go to the next slide? Can I just signal? Yeah, authors declare no conflict of interest regarding this study. Parathyroidectomy is the definitive therapy for PHPT, and bone mineral density gain is known as positive outcomes of the surgery. There is substantial inter-individual variability in degrees of BMD gain after parathyroidectomy, suggesting the clinical importance of predictors for surgical outcomes. Although many biochemical parameters have previously been shown to affect BMD levels after parathyroidectomy, few studies have determined whether preoperative skeletal muscle mass can predict the degree of postoperative BMD change. Intact muscle levels are known to be inversely associated with bone density reduction in an aging population. Parathyrospect-CT is currently utilized as a first-line modality to identify PHPT in Korea. And thanks to technical development, semi-automatic quantification of thoracic skeletal muscle mass is available. Thus, we aim to investigate whether thoracic muscle mass levels, secondarily assessed by preoperative SPECT-CT, may be used to predict bone density changes after parathyroidectomy in patients with PHPT. Can you please go to the next slide? Yes. This core study was conducted using electronic medical record database data of Severance Hospital, Seoul, Korea. Data of all 552 patients diagnosed with PHPT who underwent parathyrospect-CT before parathyroidectomy from November 2012 to October 2020 were initially retrieved. After review, 18 patients who did not undergo parathyrospect-CT within a 1-year period prior to parathyroidectomy and 168 patients aged under 50 were excluded. We further excluded 84 patients who did not undergo dual DEXA throughout the year that preceded surgery and 91 patients who did not undergo DEXA after surgery. Patients with secondary or tertiary hyperparathyroidism, parathyroid carcinoma, multiple endocrine neoplasia, and familiar isolated hyperparathyroidism were also excluded. Further, patients with data that included artifacts or limited views of thoracic muscle on CT, or those with missing BMD values were further excluded. A total of 130 patients remained in the final cohort. BMD at the lumbar spine, femoral neck, and total hip was measured by DEXA pre- and post-parathyroidectomy. Biochemical lab data and preoperative DEXA nearest before diagnosis was retrieved to check the status before intervention. The median period between the two DEXA images was 391.5 days. The primary outcome of estimated surgical response was annualized femoral neck BMD change. Data collection and statistical analysis were processed using STATA. Please go on to the next slide. All patients underwent parathyrospect-CT as a first-line surgical planning method. Thoracic skeletal muscles and parathyrospect-CT images were semi-automatically segmented and quantified using commercially available software DeepCatch, which used a deep neural network-based algorithm to segment and quantify body composition at a whole body level. Images above the 6th thoracic vertebral level, including shoulder muscle above the axillary area, were ambiguous and needed to be separated manually. Since most images included anatomy above the 8th thoracic vertebra, we quantified skeletal muscle volume between the 6th and 7th vertebral level for further analysis. After retrieving parathyrospect-CT DICOM files from the Severance Picture Archiving and Communication System, an enhanced CT image series were assessed using DeepCatch software. Please go on to the next slide. The records of 130 individuals with PHPT who underwent parathyroidectomy after parathyrospect-CT were analyzed. Characteristics of our study subjects are described in this table. They were in average 64.7 years old, and 81.5% were women. We divided favorable and poor surgical response group upon median femoral neck BMD change of 2.85% increase. Subjects with a favorable surgical response had lower age, lower baseline femoral neck BMD, lower baseline lumbar spine BMD, higher preoperative PTH level, higher serum calcium level, and higher serum alkaline phosphatase level than those with poor response. Please go on to the next slide. The figure shows example cases revealing muscle mass differences between patients with a poor and favorable surgical response after parathyroidectomy. While both women had similar age, BMI, and baseline femoral neck BMD, Women with higher muscle mass showed 5.65% bone gain, while the others showed poor response. Table on the right shows linear regression model for thoracic muscle volume. Thoracic muscle mass was negatively associated with preoperative PTH level independent of age, sex, BMI, and baseline female neck BMD. This result showed that patients with severe hyperparathyroidism tended to show lower muscle mass. Please go into the next slide. Yes, this table shows a model for change in bone mineral density observed pre versus 1 year post-parathyroidectomy. Higher muscle mass values at baseline were associated with increased annual percent BMD changes at the femoral neck with adjusted beta of 2.35% and lumbar spine with adjusted beta of 2.51% after adjusting for age, sex, BMI, preoperative PTH level, and baseline BMD. The average annual percent change of thank you. The average annual percent change of BMD observed at the lumbar spine, femoral neck, and total hip after parathyroidectomy was 5.0%, 4.1%, and 4.5% increase, respectively. Yes, please continue. Several in vivo and in vitro animal studies have revealed adverse effects of excessive PTH on muscle, which lead to muscle dysfunction, muscle atrophy, and cachexia in rat models. In patients with cancer, elevated levels of PTH-related peptides were associated with increased degrees of cachexia and muscle wasting, independent of hypercalcemia and tumor burden. One prospective study revealed that high PTH levels were associated with increased sarcopenia risk, and another study reported associations between high PTH levels and poor postural stability and muscle strength. In our study, we identified an independent negative association between PTH level and thoracic skeletal muscle mass in patients with PH-PT, a finding that aligns well with previous findings regarding PTH excess and muscle dysfunction. High muscle mass increases mechanical loading on bone, which facilitates the maintenance of osteocyte viability and thus strengthens bone health. Further, in vivo studies have shown that myokines derived from skeletal muscle, such as IGF-1, are capable of stimulating osteocyte growth, increasing lean muscle mass, and enhancing muscle function. These findings suggest that the association between high levels of skeletal muscle mass and increased levels of bone density gains after parathyroidectomy observed in our study might potentially be mediated by mechanical and biochemical crosstalk between bone and muscle. Further, prior studies suggested that thoracic skeletal muscle mass derived from parathyroid CT has the potential to serve as a reliable marker for whole body muscle mass, although further investigation will be needed to define clinically feasible threshold for defining sarcopenia. Our study has several limitations. Residual confounders cannot be excluded due to the retrospective study design, although we tried to adjust relevant covariates in the statistical model as much as possible. Our study revealed BMD changes after a median duration of 391.5 days after parathyroidectomy. Since increased BMD is known to persist up to 10 to 15 years after parathyroidectomy, a longer follow-up period to assess BMD changes will be needed in the future. Further, our study was limited to patients who underwent surgical treatment. The determination of whether skeletal muscle mass predicts BMD gains in patients undergoing medical treatment for PH-PT requires further investigation. In conclusion, higher thoracic muscle mass at baseline were associated with increased bone density gains after parathyroidectomy in patients with PH-PT, independent of age, sex, BMI, baseline PTH, and BMD. Skeletal muscle mass quantification, secondarily obtained from preoperative imaging studies in routine clinical practice, may facilitate the prediction of surgical outcomes in PH-PT, a finding that merits further investigation. Lastly, I dearly thank my research mentors, Professor Nam-gi Hong and Yumi Ri, for amazing support, and we also thank all members of Yonsei Bone and Mineral Research Team for their assistance. Thank you for your attention.
Thank you, Sungwon. If there's any questions, please upload them to the chat as well. So I have one question. So, you said some of the other cofactors did not play into predicting bone loss, like BMI, sex. Can you explain? It seems like it would, in a sense, like the bigger BMIs or being a female sex versus male sex, the difference, and why that didn't play. Do you think it was the small size or?
Thank you for the question. Could you please?
Oh, sorry. Is the predictors for some of the bone loss, like sex, female, male, or even body mass index, did not affect bone loss, but the imaging technology did. Can you explain maybe some of the reasons why it didn't play into fact? Because you would think practically it would affect bone loss.
Yes, thank you so much for the important point. And I think that it is because one of the reasons is because that the number of male was really small compared to number of women. So maybe that altered the statistical significance. And when we stratified the sex, we noticed that there was difference in between the two groups, and also between women and men, the muscle mass itself was really different. So I think that one of those differences made give some confusion to the data.
Okay. And what do you think about smoking as well? Was that put into the factors as well for the bone gain, since that does affect bone loss as well?
Thank you so much for another good question. We actually didn't check the smoking, and since we checked it was a retrospective study, and we checked the EMR and got the data, the lab data and the imaging data, we didn't retrieve the part of the histories, and we will indeed check the history data in the future.
Thank you.
Thank you.
Sorry, I don't mean to put you on the spot, but I think it's such an interesting point. And then what do you think about the practicality of the imaging technology? Like, how practical do you think to use it as a predictor, in real kind of world clinical setting?
Yes, I think it's a really nice point. In Severance Hospital, where I am right now, the SPECT-CT is a first-line modality in checking where the parts are to do the surgery. And we noticed that there could be some places abroad that doesn't use the SPECT-CT. So this could be one of our limitations in applying widely. But since the program we have, since the SPECT-CT is the first-time modality here, we could just we gather the information secondarily, and we don't need to do the extra processing and give more medical fee to the patients. And also the program is, it is very new, and it is using the AI technique, which we think that will be utilized well in the medical field in the future. And this program is, right now is in somewhat experimental stage, but I think it is going to be, it could be widely utilized in the future.
Great. And so what are the next steps for your research project after this, since it is retrospective? Do you plan a bigger study?
Yes, actually, we are really interested in muscle function rather than muscle mass, or BMD like values itself. And we are planning to do a in vitro, we are planning to do a rat animal study using giving them high PTH level and checking muscle functions such as jump power or activity level in this winter.
Thank you so much. So I think those were pretty much all the questions I had, if there's any other on the chat. But it was really interesting project. And how can I ask just personally how long you've worked on this project?
I worked on this project for about a year. We planned this last winter using our program in our school, the research mentoring program. So we did this in the first trimester, first semester of this year, and it didn't end. So we continued on to the second semester, and we pretty much wrapped up our study, and it's now on the revision process.
Thank you so much. It was
Thank
really
you so
wonderful.
much.
So we're going to have Dr. Mary Choi, the president of CAMA, present the certificate and award check. to you, Ms. Bohm. So thank you so much again for joining us.
Thank you. Thank you so much for having me here. It's such an honor. Thank you.
Oh, no. Oh. So we're just going to take a minute to have the award presentation because it is a big honor. So thank you again. So we're going to give a few more minutes. So thank you so much again. So we're going to actually close out. We're surprisingly on time or even a little early. So we're going to actually close this part of the session out for a coffee break until 10:45 Korean Standard Time, which is 8:45. And we'll be back at 10:45 for the next portion, which is the Hoan Prize in Medicine Laureates Forum, the 30th anniversary. So please join us again, 10:45 Korean Standard Time, AM.
Hi, William.
Hello, everyone. I'd like to welcome everyone to the Hoam Prize in Medicine Laureates Forum. Earlier today, we had the research abstract presentations from our medical students and residents, and I was so very impressed by the depth and breadth of their research projects. And now we will meet 3 Hoam Prize laureates who have been able to develop their scientific research career and really reach the top of their respective fields. So as a brief background on what Hoam Prize is, it's named after Hoam, which was the pen name of Samsung's first chairman, Lee Byung-chul. And Hoam means filling up a space with clear water, as in lakes, and being unshakable as a large rock. So Hoam Prize literally means Lake and Rock Award. And it's an annual award sponsored by Samsung and presented to ethnic Koreans who have made outstanding contributions to the development of science and culture and enhancement of the welfare of mankind. So I'd like to introduce each of the 3 Hoam Prize in Medicine laureates who are also National Academy Medicine members and preeminent physician scientists. So it's my pleasure to have all 3 join us for this session. So I will start with the introduction of Dr. Dennis Choi, the 1997 Hoam Prize in Medicine laureate, and he's joining us online. Dr. Dennis Choi is professor of neurology at Stony Brook University. He previously served as a director of the Brain Science Institute at the Korean Institute of Science and Technology, or KIST. Executive Vice President of the Simons Foundation, Vice President of the Academic Health Affairs at Emory University, Executive Vice President of the Neuroscience at Merck Research Lab, and Head of Neurology at Washington University Medical School. He received his MD from the Harvard-MIT Health Sciences and Technology program, as well as a PhD in pharmacology and neurology residency training at Harvard. As a fellow of the American Association of Advancement of Science and a member of the National Academy of Medicine, he has served previously as the president of the Society for Neuroscience, vice president of the American Neurological Association, and chairman of the U.S.-Canada Regional Committee of International Brain Research Organization. He's been a member of the board of Life Sciences of the National Academy of Sciences, the Nervous System Drugs Advisory Committee to the U.S. FDA, and counsels for National Institute of Neurological Disorders and Stroke, the NIA, the National Institute of Aging, the Winter Conference for Brain Research, the International Society of Cerebral Blood Flow and Metabolism, and the Neurotrauma Society, as well as a member of the advisory board for multiple companies and nonprofit diseases. His research has been in the development of field of neuroprotection, identifying mechanisms responsible for nervous system injury, and especially related to ischemia and trauma, and developing therapeutic countermeasures. We have a short video presentation to surprise Dr. Dennis Choi this evening. So can we have the video, please?
삼성복지재단이 올해 학술 발전과 인류 복지 증진에 기여한 인물에게 주는 호암상 수상자 5명이 결정됐습니다. 과학상에는 유혁 미국 위스콘신대 교수, 공학상에는 서남표 미국 MIT대 교수, 의학상에는 최원규 미국 워싱턴대 교수, 예술상에는 지휘자 정명훈 씨, 사회봉사상에는 양복규 동암재활원 이사장이 각각 선정됐습니다. 97 호암상 시상식이 각계 인사 900여 명이 참석한 가운데 오늘 호암아트홀에서 열렸습니다. 오늘 시상식에서는 예술상의 아시아 필하모닉 오케스트라 상임지휘자 정명훈 씨, 과학상의 유혁 미국 위스콘신대 교수, 공학상의 서남표 미 MIT 공대 교수, 의학상의 최원규 미 워싱턴대 교수, 사회봉사상의 양복규 동암재활원 이사장 등 사회 각 분야에서 뛰어난 업적을 남긴 5명이 상을 받았습니다.
So we just watched the actual news footage at the time Dr. Dennis Choi received his Hoam Prize in Medicine Award in 1997. welcome Dr. Choi to today's forum. I left it untranslated because I wanted to kind of keep the original video footage, so those who didn't understand Korean, I apologize. Next, I'd like to introduce Dr. William Han, the 2010 Hoan Prize in Medicine laureate. Dr. Han is the William Rosenberg Professor of Medicine in the Department of Medical Oncology at the Dana-Farber Cancer Institute and Harvard Medical School, and a member of the Broad Institute of MIT and Harvard. He also served as Executive Vice President and the Chief Operating Officer at the Dana-Farber Cancer Institute. Dr. Han received his MD and PhD from Harvard Medical School in 1994. He then completed clinical training in internal medicine at Massachusetts General Hospital and medical oncology at Dana-Farber Cancer Institute. Dr. Han has made numerous discoveries that have informed our current molecular understanding of cancer and that have formed the foundation of translational studies. And importantly, in particular, the activation and the role of the reverse transcriptase telomerase playing an essential role in malignant transformation. Together with his colleague at the Broad Institute, he also helped develop genome-scale tools and technology to perform somatic cell genetics in human cells. His laboratory has also pioneered the use of integrated functional genomic approaches to identify and validate cancer targets. The tools and models and approaches that his laboratory has developed are widely used worldwide to discover and validate molecularly targeted cancer therapies. Dr. Han and his collaborators created the cancer dependency map and are engaged in defining rational approaches to designing combination therapies for cancer. Dr. Han has served as the president of the ASCI and has been elected to the Association of American Physicians and most recently the National Academy of Medicine. Dr. Han is the recipient of many additional honors and awards, including Wilson S. Stone Award from the MD Anderson Cancer Center for Outstanding Research in Cancer, a Howard Temin Award from the National Cancer Institute, and of course the Hoan Prize in Medicine Award in 2010. And we have a short video for Dr. Han.
다음은 의학상입니다.
암 정복에 관한 새로운 도전으로 의학계의 관심을 집중시킨 세계적인 종양학자 윌리엄 한 박사. 그는 암 발생에 관한 독창적 패러다임을 제시하며 인류의 건강한 삶을 위한 획기적인 대안을 마련하고 있다. 사람의 염색체 양 끝에부터 세포의 수명을 조절하는 텔로미어. 이 텔로미어를 만드는 효소인 텔로머라제가 정상세포를 암세포로 변환시키는 데 중요한 역할을 하고 있음을 새롭게 발견한 이가 바로 윌리엄 한 박사이다. 그는 유방암, 폐암, 대장암 등을 일으키는 새로운 암 유전자들과 암 억제 유전자를 발견했으며 세계 최초로 이러한 유전자들의 조합을 통해 다양한 암세포를 생성하는 데 성공했다.
He has laid bare all sorts of mechanisms we never suspected that play critical roles in cancer. And he's done it in a way that's systematic. It's not just answering particular questions, which of course it is, but it's creating tools that let you address this in any cancer. And I think really, to his enormous credit, he's made those tools broadly available to investigators around the world.
인류의 건강한 삶을 위해 공헌하고 싶다는 윌리엄 한 박사. 생명현상 연구에 대한 그의 끊임없는 도전으로 인류는 암 정복의 꿈에 더 가까이 다가서고 있다.
So this was the video that was actually played at the Hoam Prize Award ceremony in 2010. So welcome, Dr. Han, to today's forum. And next, I'd like to introduce our third Hoam Prize in Medicine laureate, Dean Augustine Choi. Dr. Augustine Choi is the Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. And prior to his appointment as Dean, he served as the Chairman of the Department of Medicine and at Weill Cornell Medicine and Physician-in-Chief of the New York Presbyterian Weill Cornell Medical Center. Before joining NYP and Weill Cornell Medicine, Dr. Choi was the Parker B. Francis Professor of Medicine at Harvard Medical School and the Chief of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital. He received his MD from University of Louisville, completed his internal medicine residency at Duke University Medical Center, and he then pursued his pulmonary and critical care medicine fellowship at Johns Hopkins and subsequently became a faculty member there, and then moved on to Yale and served as the chief of the Division of Pulmonary Allergy and Critical Care Medicine at University of Pittsburgh, and then on to Harvard Medical School and Brigham and Women's Hospital. He has a long-standing commitment to the training of physician scientists, and his research interest had focused on the regulation and function of stress response genes in response to oxidative stress, and has translated 2 decades of his basic discoveries made in the signaling pathways and function of hemoxygenase and its byproduct carbon monoxide to patients with lung and vascular diseases. Dr. Choi has authored more than 365 peer-reviewed manuscripts and is currently the PI of multiple NIH R01s and program project. He's also a member of the American Society of Clinical Investigation, the Association of American Physicians, and the recipient of the American Thoracic Society's Recognition Award for Scientific Accomplishment and the Amberson Lecture, the top research award in the International Thoracic Society community. He's also an elected member of National Academy of Medicine. So let's have Dr. Choi's video.
남들과는 다르게 세상을 보는 사람들. 그들에 의해 세상은 바뀐다. 무색, 무취의 기체 일산화탄소. 지난 50년 동안 사람들은 일산화탄소를 인체에 유해한 물질이라고 생각했다. 그러나 누구도 생각지 못했던 일산화탄소의 순기능을 세계 최초로 밝혀낸 사람이었다. 일산화탄소는 대기 중에만 존재하는 것이 아니다. 우리 몸의 신진대사 과정에서도 일산화탄소는 발생한다. 최명근 박사는 체내에서 발생한 일산화탄소가 세포가 없어지거나 염증이 발생하는 것을 억제한다는 사실을 최초로 밝혀냈다. 뿐만 아니라 저농도 일산화탄소 흡입을 통한 새로운 치료법을 개발하여 현대의학에서 치료가 어려운 특이호흡기 질환 및 염증 질환 등 난치병 치료에 새로운 가능성을 열어가고 있다.
It's entirely new idea to me. How the carbon monoxide was poison. It's what kills people when they get a car and they don't get rid of the carbon monoxide.
발상의 전환을 통해 남들과 다르게 일산화탄소를 바라본 최명근 박사. 그가 이루어갈 건강한 세상을 기대한다.
Okay. So welcome everyone and welcome to our 3 Hoam Prize laureates. I'd like to first begin this forum. This is an interactive forum and we'll have our 2 online laureates joining us. I'd like to first begin with asking each one of you to describe your seminal discoveries, highlights of your seminal discoveries. I know a few minutes isn't enough, but just to, with the introduction that videos that we saw, just to describe perhaps its importance or significance to medicine, and importantly, how you really got into that line of research. So, Dr. Dennis Choi, we begin with you. Just brief description of your seminal work that led to the Hoan Prize and its significance to medicine broadly, and importantly, we are curious to know how you got into that line of research.
Sure. First, thank you for having me here, and thank you for the kind introduction. The work that was so generously recognized by the Hoan Prize Committee was work that I did at Stanford University initially, and then later Washington University in the mid-1980s and then the 1990s. The work was basically the work was focused on identifying how the brain's primary excitatory neurotransmitter, glutamate, kills neurons in pathological conditions such as stroke. So to put this in some context, in the 1980s, cell death in general was just emerging as a major focus of research, driven by work by people like Bob Horvitz and others in cancer and other fields. In neuroscience, cell death was really pretty much off the radar screen, and neurodegenerative diseases, whether stroke, acute like stroke, or chronic like Alzheimer's disease, were really not thought to be something that was of medical interest, something that anybody could do anything about. But at the time, glutamate had been identified really by the early 80s as a neurotransmitter. And then increasing work had begun to implicate a peculiar ability of glutamate to kill neurons under conditions of overexposure in pathological states like stroke and brain trauma and the like. And so the work I launched was aimed at trying to understand how glutamate affected this death. How did glutamate kill cells? And we worked in a cell culture system and identified that a critical first step was the gating of a subclass of glutamate receptors, the famous NMDA receptors, which open calcium channels, and calcium overload was a critical next messenger that drove a number of ultimately lethal processes, including the generation of free radicals. And so this work led to a lot of interest in trying to interdict mechanisms of glutamate neurotoxicity, including blocking NMDA receptors, and a number of companies developed NMDA antagonists for potential use in stroke, et cetera. So that was really the work that I think was recognized.
Excellent. Thank you for that summary, Dr. Han.
Well, thank you for the organizers for including me in this year's symposium and this session. So the work that I have been involved in for my entire career really is a very simple question, and that is how many mutations does it take to make a cancer? And unlike many monogenic diseases, cancer is a genetic disease, but requires multiple mutations. And the observations that we made was that you could take a limited number of changes, put them together, and in much the same way as you can make a iPS cell, you can turn a normal cell into a cancer cell. And that very simple experiment, I think, opened the door to saying that there is a wiring diagram that gets disrupted in cancer, and that we can define what are the things that interrupt that diagram, because you can't take any combination of genes and get cancer, and so it requires a certain set of things to be changed. And it's been our long-term and continuing interest to say, if we could understand what are the rules that govern that transition from being a normal cell into a cancer cell, and it taking several steps, we could have a rational path for thinking about combination therapy, as opposed to doing what we normally do in medicine, and that is to take something that works partially, something else that works partially, and mixing them together and see if they work better together. And there's nothing wrong with that approach. It's an empirical approach that's been used widely. But given the complexity of mutations in cancers and the number of new drugs that are available, it will be decades before you hit upon the right combination. So coming up with a rational approach has really, the work that the HOAM Foundation recognized was the foundation for us to start on a path of trying to understand this process and to think about a rational approach to combination therapy. I'll say that we're still not there yet. And it continues to be a challenging and vexing, but also a rewarding problem to work on.
Thank you for the comment. And Dean Choi, would you like to describe?
So I kind of stumbled into the line of research in terms of carbon monoxide. So as a lung physiologist, I was very interested in how the lung defends against the oxidant stresses and toxins that we breathe in. The lung is the only organ, as all of you know, that's exposed to ambient air. And for decades, investigators have studied the role of antioxidants in lung diseases, and it just has not panned out to the way that we want it to be, including therapy. So it's been known for decades, since 1940s, that we produce carbon monoxide. All cells produce carbon monoxide, about 10 mils of exhale CO daily. And it was taught to our students and in textbooks that it's just a toxin. And of course, cells produce toxins, other toxins, but to make a long story short, we thought, why don't we do some experiments looking at physiological dose of CO, not the toxic dose of CO that we all know kills us by binding the hemoglobin. So to make a long story short, we started with cell culture models, infusing low levels, physiological levels that we produce daily of CO, and it had significant cytoprotection in cells. Then, of course, we went to mouse, and then, of course, we were very excited about that. We actually had trouble publishing this paper for 5 years. So probably a total of 10 years before we published this, because it takes years to generate the data. And so we applied to FDA for IND to go to humans, and of course, because this is CO, they wanted us to prove the concept in higher animals, in primates and so forth. And it showed significant cytoprotection. The mechanism of that, we still don't know the precise mechanism, but it's a very potent anti-inflammatory molecule, potent anti-apoptotic molecule, and a potent anti-proliferative molecule. So now, after 25, 30 years of research, we have now done 3 phase 1 trials in lung diseases, ARDS, interstitial IPF, idiopathic pulmonary fibrosis, and sepsis. So now we have successfully done phase 2 trials in 2 diseases, and we are now at the fork where we are ready to do the registrational phase 3 trial, which is hard to get funding for through the usual NIH mechanism. So we're trying to get venture capital funding to do the next phase 3 trial. So it's been a long haul. I have to credit all of my brilliant postdoctoral fellows and students who never gave up. We went through years of ridicule and, quite frankly, attacks at the science, but now I think the place of carbon monoxide is treated as a second messenger, just like nitric oxide and other gaseous molecules. So that's how we kind of stumble into this field, and keeping our fingers crossed that it will have some efficacies when we do the phase 3 trials going forward.
Thank you for the comment. And I want to segue from the comment that Dean Choi just made. I mean, we always think that when the highly accomplished scientists, we think that they've risen. They must not have had any stumbling blocks. They just went on and, marched right up. And Dean Choi just mentioned his sort of stumbling blocks, difficulty getting published, and so forth. And I'd like to hear from Dr. Dennis Choi as well as Dr. Han about whether there were equally challenging events during your career, and if you could describe and how you actually handled or was able to overcome. So Dr. Choi first, Dr. Dennis Choi.
Sure. So stumbling blocks, I would say yes, too many to count, but I will, let me outline two. A small one at the beginning of my career, sort of a more personal note, since I didn't really address your question of how I got into excitotoxic cell death, and then a larger one. So the local one was, I didn't set out to study excitotoxic cell death. I actually, when I finished my training and my residency training in neurology, my first job, I was really, I wrote an NIH grant, and I was really launched to try to study membrane physiology, specifically the NMDA receptor and some puzzles around its channel conductance. So I was trained as an electrophysiologist. And then shortly after I got my NIH grant, I picked up a journal and read the answers to everything that I had proposed to study. It was all done. Beautiful work that had been accomplished by Philippe Bacher and Mayer and Westbrook. So I basically had a grant and nothing to study, since it all had been definitively answered. And that put me in a position of basically a little bit like the guy with a hammer looking for nails. I had a certain skill set and a limited number of things I could do in my laboratory involving glutamate. And I needed to find a problem to study. And basically this idea of this emergent glutamate neurotoxicity came across my desk, and I started to study that. So that was a local stumbling block, and I credit the NIH for their flexibility in letting me take grants that were awarded for one purpose and use it for entirely something else. A larger stumbling block comes to the end of the story that I outlined, which is that because there was all this interest in glutamate excitotoxicity and NMDA receptors as a driver of brain damage under conditions of brain ischemia, and all these companies made NMDA antagonists. So what happened with all that? They all failed. So I call that a big stumbling block. And these failures occurred in the 1990s and early 2000s. So basically, for the past 15 years or so, the idea of blocking glutamate in the ischemic brain has been pretty much dead. So very little interest. But it's slowly starting to come back to life. I wrote a review on this last year in Frontiers in Neuroscience, if anybody wants to read some gory details. But I'll just say that it's slowly coming back to life, and there are now a couple of companies moving into advanced clinical trials of what I'll call second-generation NMDA antagonists. One in Canada, and interestingly, one in Korea, and the company's name is GNT. And they're about to move into phase 3 trials of a second-generation NMDA antagonist for stroke, with the trials to be conducted both in China and in South Korea.
It's the NIH being generous and allowing you to change directions. That doesn't always happen, does it?
No, it doesn't, but I was very grateful at the time, as you can imagine.
Dr. Han, any stumbling blocks, or you just sailed right through?
No, I think Dennis said it well. There's too numerous to count in terms of stumbling blocks. I often tell my students and trainees that they're heading out in a ego-crushing career. It's one in which you put your ideas and your work out in front of people on a daily basis to get criticized, to get torn apart bit by bit, sometimes fair, sometimes unfair, and it takes a lot of fortitude to look through that and see what are the things that people are trying to tell you that will make your science better. And I think that that's part of the scientific method. And it took me, I think it takes all of us a long time to learn that that is the best way to ensure that your science is as good as it can be, is to let others, you know, have at it. You know, I think that there's, as you know, one of the great things that's going on in cancer now is that the path from discovery to translation to clinical trials is gotten shorter and shorter and shorter. And people are impatient now if things take months when they used to take years or decades. But it's still a continual challenge to sometimes get people to, you know, want to move forward with an idea in which there's good data, because you know, there are 100 reasons why you know, someone can devote the resources to do that. And I think that that is something that on a daily basis or a frequent basis, you're trying to understand, well, do I really still believe in my idea? And if I do, how can I be creative and persistent and undeterred to find somebody who's willing to work with me on it? And you can't just, you have to learn how to not waste time with people who have decided for whatever reason, good or bad, that this is not something they're willing to do at that time. And all of that just is, at the moment, it feels like the world is just too hard a place to be. But it passes and things move forward. So I guess if I were going to give people a message, don't give up, because you know, things will work out. And if you stick to your, you know, you have to believe your data. And if you believe your data, then you should stick with it.
Perseverance. Stick with what you want to do. Excellent advice. So we've sort of emphasized on the stumbling block and, you know, need for really persevering, but there must be something fun about research as well. Dean Choi, do you want to comment about, you know, what's fun about research for you?
Well, I think it's the aha moment. So as Bill and Dennis mentioned, there's a lot of challenges when you're trying to make new knowledge or discover unknown knowledge. I tell my fellows when clinically that, you know, as a bronchoscopist, when you're trying to learn how to get into the superior segment of the lower lobe, which is the final stage that you can be an independent bronchoscopist, that's knowledge, but it's not new knowledge. That's quite different. And other examples of knowledge that people have already discovered is if you are a medical student and you want to learn the gas equation or mechanics of lung physiology, that's known knowledge. Yes, you need to study it and acquire the knowledge. But when you're doing research, whether it's basic, clinical, or translational, you're making fundamental discoveries of unknown knowledge, and that takes discipline, time, perseverance that was mentioned by Bill and Dennis, and that takes time. And so the fun of research is the aha moment after months and even years of navigating through this, the challenges of trying to make discoveries. That's what is so fun and fulfilling. And not only because of your contributions, but the impact it has on your laboratory, from technicians to students to postdoctoral fellows. It's a team approach. And I think that aha moment, there are not many, but enough to keep going. And I always tell my trainees that if you don't have an aha moment after you make a discovery, then I think your gods are telling you that perhaps you need to consider other noble career paths, right? We all went to medical school to be a doctor. So, so my advice to the young folks is that the fulfillment of making that discovery is just really fun and worthwhile. And that's how I have treated this for the last 30 years of my career.
And I agree that there has to be something fun, otherwise you won't stick with it, correct? Dr. Dennis Choi, do you have Um, your comments on this topic of what's fun for you? Do you find research fun?
Not every day, but yes, absolutely. So of course it's meaningful work, and as Augustine said, it's intellectually richly rewarding when one has an accomplishment. I'll highlight a people side. Being a researcher gives you membership in an international community, and these are people that you may not know, you might not have known at all before you meet them at a meeting, but you suddenly have a deep connection with them, and you know you have a deep shared interest. And so it was really this feeling that I was suddenly, through my research, connected to people throughout the world that it was and is such an exciting part of the career. I remember right in my early days, going back to that, when I had a chance to begin to travel, and that was very exciting. And I went to an international meeting in Copenhagen, and a famous neuropathologist who I'd never met but admired his work told me that he wanted to talk with me, and he took a day off from work, and he said, "Let's hang out together and let me show you Copenhagen." And I thought, this is such a marvelous thing. It was the sort of thing a dear friend would do, and it was such a generous act, and we were connected by our interest in excitotoxicity and glutamate. I had a wonderful experience and got to see some parts of Copenhagen that I never would have seen by myself. So, or you could say more recently, my appointment to KIST gave me an opportunity to meet many people in South Korea that I hadn't known and would never have known if it had not been my research career.
I actually have a line on why do research. I have several reasons why I do research when I speak to the medical students and residents, and one of the lines says you get to travel. So completely agree with your comment. Dr. Hahn, what's fun for you in research?
Well, going back to when I started in the lab as an undergraduate, I was a college student and had in my mind that I was going to be an oncologist and a clinician and take care of patients. And I was really in the lab because it was part of what my undergraduate training, there was a component of working in the lab. And I remember clearly that I was working on samples from an ovarian cancer patient. And, in the course of a couple of days, we collected the samples directly from the patient's ascites fluid, isolated the biochemical materials we were going to do, and I did an experiment. And at the end of the experiment, which worked, I realized that I was an undergraduate, not a trained scientist, and I was the first person in the world to know this result. And that really had an impact on me. And I thought, well, cancer at the time was mostly palliative care with one or two diseases where people could be treated with horribly toxic therapies. And I thought, this is great. This science is exciting to do. It's not like reading about experiments in textbooks. You're doing, you don't have to be trained for decades before you can even read the literature. You can do this as an undergraduate. This is a great field to be in. And I still enjoy that part of science, that there is an immediacy to it, and knowing that you or your lab or your group are the first people to discover something is always an exciting event for me. I think the other thing I've learned is with time, what happens is if you succeed at being a scientist, and often if you complain about things not working, they ask you to become partly an administrator to help fix things and to manage things. And so as I spend a fair amount of my time doing that these days, science is actually the part that I enjoy the most, because I'm still running my lab, and the time I spend thinking about science is the part of the most enjoyable parts of my days and weeks. The other stuff's important. It allows an institution to continue to focus on science in general, and you can impact many people's science over not just your own. But I treasure the time every day that I spend with my students looking at primary data, thinking about what we're going to do next, and even writing the manuscripts.
Outstanding. Yesterday, we had a lot of discussion, particularly in Women in Medicine Forum, about importance of mentorship and sponsorship. Just to switch a little bit, I know all three of you are great mentors to many, but I wonder if you could comment about your own mentors and sponsors that you had along the way that was, an important part of your success. Dr. Dennis Choi, do you want to begin with that? And, is it who played big roles for you in your career path?
It's a bit of a too many not to count, but to talk about here. But in terms of, if I go back far enough, I'll highlight two people who I think really had a massive impact on what I ended up doing. The first person I would identify is my grandmother, Harmony, who single-handedly, I think, shifted my career trajectory from what likely would have been a blue-collar type career. I probably would be an auto mechanic today if it weren't for grandmother Florence. And she said, no, you can do anything. And ultimately, through her single actions, got me admitted on a scholarship to a Boston prep school, and that opened doors to ultimately an academic style career. So I really think her message of, you can do anything if you try and you put your mind to it. And then I would secondly highlight my high school science teacher who really encouraged me to develop my interest in scientists. And he everybody called him Doc. It was Doc Walters at a school called, at the time, Brown and Nichols in Cambridge, Massachusetts.
How interesting. Very wise Halmoni and science teacher.
Yeah, wonderful.
Dr. Han, any, early mentors who influenced you in your path?
Yeah, I think, I've been really lucky. At every stage in my career, I've had people who took time, would, spend time looking at what I was doing, giving me good advice, helping me, see the big picture as opposed to the little picture. I have many sayings that I tell my lab when we're doing things about, how to be successful at experiments and how to think about what problems to work on. And most of them I've stolen from my mentors over the years. I don't think any of them are originally mine. And I feel like every part of at every point in my career, I have had outstanding mentors. I'd also say that, I'm sadly not someone who can call themselves junior anymore. But I also feel that I still have mentors. I still look to people and I watch people who are successful all the time, and I try to see what do they do? How do they react to things? How do they handle situations? And I try to learn from each of those experiences because there are no one's perfect, but you learn a lot from different types of leaders, different types of ways of mentoring people, and I don't always succeed, but I like to try to pick up things from other people, and so I think that you never stop being mentored in your career.
Agree. A mentor needs a mentor too. Okay, Dean Choi.
Well, this is a passion of mine. I think mentoring I think we, the community, academic medicine, we do well in training our students and trainees in research, clinical training, education. But we don't do as well in mentoring, and that's a challenge going forward. If you write a grant, 30% of the time you'll get paid once you get the grant. You see a patient, you get 40 cents per every dollar, you get paid. Now you even get taught to teach by getting protected time to teach. But in our community, we just don't have a way to support mentors. As all of us know, you could be spending an hour on a grant that you felt your trainee is writing. That's 2 new patient workups that you're losing out. But other than a tap on the shoulder, maybe by your chief, depending how passionate the person is, you don't really get much back. And I think that's the challenges, the fourth thread, if you will. And I think the institutions have to find a way to not reward, because mentorship is selfless, but you have to provide this resources for the faculty and junior or senior to provide the mentorship. And because the power of mentoring is the only thing that's really sustainable. Grants only last 2 years, 3 years, 5 years. Then you got to prove yourself again. Clinical work, you're only as good as your last patient. But mentoring is sustainable. So I think Bill and Dennis mentioned about long-term mentors, and Mary, you mentioned about once a mentor, always a mentee, a mentor. That is so powerful. And I do want to add, just in the spirit of karma also, Dennis Choi, who I've never met when I was a young junior faculty, when he was publishing just seminal papers, not even in my field, I'm a pulmonologist. We were doing a journal club on overdose of benzodiazepines in ICU. And some student, it was a medical student, came up with this, the paper that Dennis wrote, that benzodiazepines activate the GABA receptors, and now we have a mechanism of that. And of course, I noted the first author, D. Choi, and I think that's part of the heritage and what culture brings too. And Bill Hahn, when he was publishing seminal papers in telomerase, Bill, I had not met you then. We were still in Boston together. But when I saw the name Han, it was a Korean physician scientist. So I think in terms of the connectivity, and I'll end by saying this. Students and residents and faculty tell me that in this era of diversity, we want to be taught and mentored by people who look like me. And there's actually data that medical students looking up for house staff to faculty, and junior faculty to department chairs, that the career development and the well-being index is better when they have more interactions with people who look like them. And I think that's a power of mentoring, and in the spirit of the theme, diversity being a big part of this 2021 CAMA scientific convention, I think we have the responsibility. And we heard a great talk by our student from Yonsei who won the CAMSA Abstract Award. It's just beautiful to see the sustainability of what mentoring can do. And we use the word role models and mentoring very freely, but it's a very to me, a very earned title that you have, and we all have the responsibilities to really fulfill our duties to be as good of a mentor as you can be, and as good of a role models we can be to our trainees.
Thank you for those important comments, and you touched upon actually one of the reasons why, I really insisted, had this vision of having our CAMA convention in Seoul. It's just the pandemic got in the way, and we weren't able to have our two Hoam laureates who are online, to have them here in Seoul. But the influence and the fact that we're all Koreans. I mean, some of us were born in the U.S. Some of us immigrated at young age and grew up, all in the U.S. And yet, deep inside, in the back, we're still Koreans. And Dean Choi just mentioned about the influence of Korean heritage and the need to keep that connection. Dr. Dennis Choi, would you want to comment? Did your Korean heritage influence you in any way in the career path, your career goals? You mentioned about your halmoni, which, but is there something special or the heritage influenced you in a meaningful way?
Well, for me, it would very much, the major influence in that category would definitely be Harmony. I watched her emigrate to the United States with not so good English, hit the ground running, and pretty much immediately immerse herself in all kinds of activities, the Red Cross, things that she wanted to do. And she was just fearless. She would just plunge into things. She wouldn't know how it worked, but that didn't bother her. She would just charge in and get involved and make things happen. And I guess that can-do fearlessness was really a very powerful driver. I'll mention something else, though, which is a little bit orthogonal to your question, but related. And that is that, interestingly, at the time that I started to think about medicine, was really a transition point, I think, broadly, where Asians in America began to enter medicine in large numbers. And I mention that because specifically my mother had advised me when I began to talk a little bit about going into medicine, that she didn't think it was a good idea. And that because in her generation, I think there was much more discrimination against Asians that she experienced. And so when I was contemplating entering medicine, and that would have been the 70s, she said, it may not be a good career for you. You may find yourself not so accepted. You may find it hard to build a practice. And interestingly, that was fading. Unfortunately, that was fading. And so by the time I was a resident in the later 70s, I saw no problems, and it was clearly happening. And larger numbers of Asians, of course, have entered medicine in the United States, and now Asians are certainly an overrepresented minority in America. So you could say that my Asian heritage, my Korean heritage, was, in a sense, an obstacle that I had to think about. And then to my good luck, it faded as social change occurred.
How interesting that it can be a positive and a negative influence, and yet the negative turns out to be positive. Dr. Han, do you have, tell us if your Korean heritage had any influence in your career development and your goals?
Well, I certainly think as having Korean parents and growing up in the 80s in the United States, there was a strong influence and desire for parents to have their kids go into fields like medicine. So that certainly was, Koreans are not the only group that feels that way about their kids, but it was certainly almost a joke amongst kids my age when they were in college. But I would say that, over time, it's interesting. I've never lived in Korea for any significant length of time. I've visited for some periods of time. But you always go back to your heritage. And I think, my parents were Korean. They emigrated to the United States. My wife is Korean American, just like me. And there's a shared set of experiences, some that are Korean, some that are Korean American, some that are American. And, I think that, naturally was something that brought us together. And now my daughter is, she's American, but she's the product of two Korean Americans. And what's amazing to me is that she has a strong identity as a Korean American and loves Korean food and loves language. And, if the pandemic hadn't occurred, we would have brought her to visit Korea over the last couple of years. We still have to do that. But it's, it almost raises those questions of nurture and nature. when you see your children gravitate to something they've never actually experienced except through you, and that's really a remarkable thing about society.
How true. Korean food always gets everyone excited and want to, we're always talking about food, but yeah, it's interesting that our second generation, and for you, Bill, I guess your third generation children, are, even though they've never lived, in Korea, still identify themselves as Korean and enjoy all things about Korean food, obviously, but just the culture and perhaps even sort of an inherent attitude inside. But something about being Korean, I think, is very special. So thank you for all three of you comments. So I want to touch upon our students and training physicians, and we have our abstract winner still with us from Yonsei, and as mentioned, she gave a wonderful presentation. What's your advice for our students in encouraging them to choose the career path that you all, all three of you chose, to be really physician scientists and to be the best physician scientists in respective fields? Important advice for our students in training, very important for me, that they not only get mentored, but they're always asking, how do I find mentors? What's your advice? Have comments and your roles in that respect?
I can start. Every year we have about 1,000 Korean medical students graduate from U.S. medical school. And that's been the trend for the last almost 2 decades. And Dennis mentioned that when he went to medical school in the 1970s, it was the start of that. So over the years, there's now a growing cohort of Koreans who have become physicians in the United States. And I think that it's powerful. It's something that we need to leverage. And in the spirit of karma, I think that's the future, because they all become residents, they'll become faculty members, some of them, who choose an academic career. And the Korean students have so much to offer with all the positives that you know. The one area that I think the Korean, and there's data for this, actually was published in PNAS, not in medicine, but in law and business. But the Pacific Asians, and generally it was Chinese and Koreans, they're overrepresented, but in the areas of leadership and seniority, they're very underrepresented, as you know. The South Asians, it's the reverse. So there was actually a social scientist who is still studying that on why is there such a cultural divide that really divides the line between South Asians versus the Pacific Asians. And I think the Korean students in the US, I think they're very talented, smart, motivated, hardworking. I hope that they get bolder and really to foster their career development. And I think in the spirit of karma, all of us who are not trainees now, but whether you're a physician or a doctor or academician, we have the responsibility to build on the amazing Korean student cohort we have in the US, that in 20, 30 years in their lifetime, that we'll have a bigger voice to really have impact on our society, whether it's research, clinical, or education and training. And I think there's exciting times for karma. This is a pivotal time for karma, and we need all of you. And Bill and Dennis, you're the role models of our Korean trainees and faculty members, and we need to continue to do that.
Absolutely, very important. Other additional advice for our students and residents? How do you foresee? How do you encourage them that this is a career path that is worthwhile? How do you steer them to see that it's not all work. There's some play in it. There's some, as you mentioned, there's joys and fun about research.
Well, I would just say that it's really important to find something that you're very passionate about. You know, whatever field, whatever problem, whatever question you want to try to answer, focus on the ones that you care about, not the ones that someone else say are the things that, you know, are the hot fields or the, you know, if you love what you do, then the work is not work. It's something that you would do gladly because it is exactly what you want to do. The other piece of advice I give people is something that, as I said, I've stolen from other mentors is work on important problems because they're only a little harder than working on incremental problems. And so you might as well spend your time working on a problem that somebody cares about because it's still pretty hard to work on a pretty minor incremental problem. So, you know, that advice has always served me well, that, you know, if there's a decision point about what to do next, think about the one that, you know, answers a big question because it's worth it.
Excellent comment, Dr. Dennis Choi. Anything else you want to comment or add about our students and training training physicians and their sort of career path, and to encourage a physician-scientist type of career?
Mary, I think the key word is encouragement, because the career, it's a great career, and you have an opportunity to work on the questions that matter and make a difference, as Bill said. Maybe I could mention a couple of advantages that one has as a physician scientist. So one advantage is that you operate in bridge space. And that means that you are in a relatively small group of physician scientists, and the world needs more. So that's an encouragement. There are no unemployed physician scientists. There's a worldwide need for physician scientists. So you will find eager employment, and you'll be in bridge space. You'll have an opportunity to draw from two different related areas, and in this relatively rarefied space, there's just so many things you can do. And there's a synergy in the fundamental training of a laboratory researcher. It's not the only kind of scientist, but all three of us are examples of laboratory scientists. And there's a synergy between laboratory science and medical science that turns out to be very advantageous, I think, in both arenas, both in doing bench research and in clinical medicine. And there's, I think, laboratory scientists are really trained to take problems apart, reductionist approaches, and break them down and solve them in a stepwise, analytical, and logical fashion. And I think medical training is really great at giving a big picture approach, multi-systems, pattern recognition. And I think these two fundamentally different but complementary modes of problem solving turn out to be very, very useful tools that one is then advantaged by in engaging in either bench research or clinical medicine. So, yes, the hill is steep, and yes, no one should consider a physician scientist career if they don't, have the passion and the stamina. But the career is fun. It is certainly meaningful and rewarding in a very broad sense. And one has actual advantages along the way by being part of a needed minority, by being a bridge person, and by having the great advantage of formal training in two different modes of problem solving.
Thank you. You bring up great points. I think in the last 5 minutes or so, I want to just ask you, each of you, about what's next for you. Where are you going? Dr. Han, do you want to start first? We would like to know.
Well, like I said, we're still engaged in this problem of how do you define the wiring diagram, and how do you use that to rationally define combination therapies. The science in my lab is still compelling to me, and increasingly we're seeing work get translated. So that will continue to be a big focus of mine. I have taken on some administrative responsibilities. I've learned a lot of the business of what it takes to run an academic medical center, how to run a hospital, in the middle of a pandemic. What I'd say is, I'm doing a job right now with a lot of my time that I've never been trained to do. It's the first time I think in my life I'm doing something that I never aspired to do. And it turns out that I like it, and I enjoy learning about different aspects of how things work, in part because it's critical to have institutions that are committed to doing science and committed to research and the academic mission and training. In the United States, the economics of medicine are complicated, but they're all moving away from supporting those kinds of activities. So I think I found it for me to be a very important role to stand up and say, well, we're going to run a business in a positive way, but we're going to do it in a way that allows us to focus on our mission of research, training, and education, and patient care, and not to waver from those things for financial reasons. And that's not easy these days, but it's absolutely needs to be done.
Thank you for that comment. I think the importance, and again, the role of a physician scientist point of view, doing administrative role, I think that's the impact that you'll have in that respect, not just office business, but keeping the always remembering that you're a physician first. But Dr. Dennis Choi, what's next for you?
Well, I've also done some administration in more recent years, but this seems like a good moment in time in life for me to step back from some of that. So I've recently stepped down as a chair of my department. I expect to continue to work on therapeutic development, primarily in advisory roles, and I've continued to serve as an advisor to several companies engaged in therapeutic development, including anti-excitotoxic therapies. But I would say I also want to do some other things. Number one on my list is I'd like to figure out how to make makgeolli. My first couple of efforts were unbelievably bad, but I believe this is a solvable problem, and I'd like to write a book.
How many attempts, how many experiments did you have to do to make makgeolli? You're still not successful yet?
2 was enough, and they were really bad.
Dean Choi, what's next for you?
Well, Dennis, I'll join you, but it will be sake rather than makgeolli. But so impact, I think, regardless of any administrative title that you have, whether it's dean or whatever, I think going forward, I want to have impact on people that I work with. During my active days as a researcher, as a physician scientist, I had that, of course. I still do some of that. But I think going forward, it's all about impact on young people. And I do want to end by saying that the elegance and the beauty of academic medicine, when someone decides to become a professor at age 35, it's powerful and so fulfilling, because if you look at any academic handbook of any universities in the world, in the first paragraph, what does it mention? Whether it's English or Korean or Russian, it's a transfer of knowledge to your trainees. transfer that's more than just tangible knowledge, but intangible knowledge, life aspects, scientific aspects, personal aspects. And I think we, in academic medicine, we have the responsibility to fulfill that mission, transfer of knowledge to your trainees. So in my limited capacity going forward, that's what I hope to do going forward. And Dennis, let's compare notes after you make your makgeolli and I try to buy some sake.
Okay, deal.
Well, thank you so much, Dennis, Bill, and Augustine, for this 1 hour of illuminating, insightful comments and truly inspirational. And I hope our students and training physicians, especially junior faculty, can see 3 great role models of which they can be an inspiration to everyone. Thank you so much. We'll see you back home.
Thank you, Mary. Thank you, Kama.
Thanks, everyone.
Thank you for such a wonderful panel, and it's really inspiring to see how far the Korean American medical community has grown and really has achieved so much. They've paved a very hard road for us, and it only inspires us, and I'm sure the generation following me, to do even greater things. It's hard to believe and quite emotional that we've reached this point. It's the end of our 3-day convention. And I just wanted to introduce to you the members of our leadership team who have really made this day possible and very special. I'd like to start by introducing our board chairman of KAMA, Dr. John Won.
Okay, let me just say thank you. Let me take this off. Usually, traditionally, as a sort of closing remarks, my role is actually to thank the people who made this meeting possible. And I wrote down all these things, and it's more that I at least have the names correct, and I don't skip anyone over. First, congratulations. This meeting was probably never supposed to happen, but even to the last date, about departure date, I thought for a while it wasn't going to happen, but through the resilience of everyone involved, the meeting did happen. And if I had to summarize this executive team in the last 2 years, it's really the word resilience and being together. And with that, those two formula, I think we're able to get through all these difficulties. So first of all, I want to thank the KMA president, Mr. Lee Pil-soo, Dr. Lee Pil-soo, and his staff for making this possible, certainly including inviting us over to Korea. And is Mr. Young-sam Kim here? I don't think I saw him, but from Yonsei University, I mean, he really went beyond his role to help us and make this meeting possible. Also, we have our consul, Secretary Counsel from New York, and his team, who has really worked with us, granting us quarantine exemptions and what have you to make this possible. So without those key people involved, this travel, especially in light of the recent announcement of 10-day mandatory quarantine, I think this would have been very, very difficult. Of course, the executive committee members, I'll talk about them more later. And also, I want to actually thank the hotel and the terrific audiovisual people from TSM for making this possible. And since many of the board members are not here, but I do want to mention some of them, and some of them are not no longer on the board. But Dr. Stanley Kim from New Jersey, he has been an instrumental member of CAMA board, and he was actually my right-hand person during my presidency in 2015 and 17, and he has played a tremendous role. Also, this year, we have Dr. John Oh, who I want to thank for his service to CAMA for many years. And James Park, another board member from NYU, also 2019 president, and Dr. Carl Yorita from Hawaii. And Dr. Chester Koh, he is a fellow urologist and he's been an instrumental player and always my colleague and friend. And of course, I can't forget Dr. Bryce Choi and Dr. Jeffrey An. Both of them are like my mentors who has really guided this board through any type of ordeal. So a special thank you to Dr. Bryce Choi and Jeffrey An. And I want to also, I have to mention other people who has always been involved, especially from the DC, Washington, Maryland chapter, Dr. Soyeon Park, Dr. Ingrid Chung, Jiyeon Wangi Kim, and Theodore Kim, who's been really helpful over the years. And there are current EC members who are not here, Dr. Josephine Kang, Dr. Yang Yi-woo, Patty Lee, and of course Jiwon Kim, who's been really instrumental in working with the students, and I really wish she could have been here. But anyway, I want to thank you, I thank all of them. And I hope I didn't leave anyone out. This last 2 years is really, without need to say, has been really unprecedented. As the virus swept across the globe, in the United States, New York was the epicenter, right? And we all practice in New York area, and I think we had a first-hand look at all the people who have passed away. We saw morgues next to the hospitals because they were in spaces, and there are many, many healthcare workers, many of you know, many of you involved, because we're at the hospitals where we treat these patients who risk their own lives and taking care of these patients, not knowing whether if you go in that morning, you could catch a virus and give it to your family. I know many physicians who actually didn't even live with the family initially because of uncertainties. But these healthcare workers really rose to the occasion. And one of the things I realized is that I've never been more proud to be a physician, and I think all of you probably share that same sentiment. This also comes with the cost. We at CAMA lost a very beloved board member, Dr. Chun Hoo-gun, who was in charge of the cancer center in St. Mary's Hospital, and he has passed away at the very early stage of the pandemic, and I really miss him very much. The CAMA role during this event was really for the safety of everyone, and I know Dr. Mary Choi and we had the highest priority making sure that we are all safe. By that, we seized some of the operations, but we did other good things, such as forming a COVID-19 task force. It was headed by Dr. Sang-hyun Kim and Hyunji Lee, where they did community testings. And this is all at the early stage where we really didn't know much. And we tried to offer education. We set up a hotline to answer questions. So we did all we can. We tried to get masks to donate because one of the main thing, if you recall, the PPE, right, protection equipments were far and scarce, and distinctly recall calling a company to get their mask, which they were at that time charging a little over $3 per mask, and minimum order was 100,000. So you do the math and you know how much that is. And obviously that's something that we cannot do, but there are people who've stepped up. There are people I know, for example, I have to recognize from Fila Korea, the Chairman Yoon and his son Henry Yoon, who has, at the early stage of the pandemic, donated 500,000 masks to the United States, the majority to New York, because that's where the pandemic hit. So the generosity of individuals like that has really, I think, helped. I think the pandemic has shown us a lot of things about ourselves, especially about our character, and the message I have for the EC is that from what I saw, you are a tremendous and you're a very special people, because during this rough time, you could have easily just given up and just walked away, and no one would have blamed you for that. But you all stuck together with your leader, Dr. Mary Choi, and pushed on to deliver this meeting. This meeting had to happen, and it's not just because the meeting, there's many symbolic meaning behind this, mainly that we can respond. We could come together in the times of challenge and deliver a meeting or a goal or whatever you want to do. So it's really a true reflection on yourself. And it's a very symbolic moment coming to Seoul, because think about it, having a meeting like this, hybrid meeting during the times of pandemic, is something that I think most people would decline to even undertake. So I'm very proud of all of you. And I want to say one thing about the turnout and so forth. You know, the success of the meeting is not determined by number of people who attend or people who've logged in or whatever. But really the success of the meeting is determined by your own conviction and perseverance and working together to deliver the convention. And using that measurement, you have succeeded beyond the wildest dream. And as the chairman of the board, I cannot be more proud of what you have done in the last 2 years. And you will go down in the CAMA history as one of the best executive teams, and you'll be remembered for all your sacrifices you've made. And I know some of you were even wanting to come alone first to see if this quarantine thing would even work. So you willing to make that kind of personal sacrifices to do this. So you are all remarkable individuals. I'm almost done. I have a message for Mary, who's the president. And also, she's the better half of the Dr. Augustine Choi. But you, Mary, how can I tell you? Your leadership and your perseverance is what got you here. And I know you had a lot of help, and Dr. Augustine Choi, thank you so much for being the advisor and serving as really a mentor for a lot of these people on the EC. But Mary, you did a wonderful job, okay? And to the new incoming president, Dr. Michelle Kim, she will tell you I probably tricked her into doing this, but it's not. She was my convention chair in 2017, and from what I know her and what I've seen, she's amazingly talented, she's intelligent, and she has the right makeup to lead this organization next year. I wanted to make sure Ara was Cecilia, okay, and I think we have everyone. I mentioned the executive team. Thank you so much for all the effort and everything you've done. And I'll probably get in trouble if I don't say this, but I want to thank my wife because I know that being a wife of a board chair sometimes is not easy because I carry my work to home. And she's seen me through a lot of moments up and down. And right now, my final comment is that I've never been more proud and have more confidence in this comma than any time before. As you could see, look at your brochure. We have many women on the team. We have really solidified the Women in Medicine program, solidified this medical students and resident involvement, and now our board looks very reflective of what it should look like in today's age. So with that, I wish all you safe travels back home and see you back in New York. Thank you very much.
Thank you, John, for your encouragement and those words. And next, it is my absolute pleasure to introduce our president, whom no introduction is needed because she's been here for all 3 days, but our president of CAMA for 2020 and 2021, Dr. Mary Choi.
Thank you, thank you. I wrote a few things down, and there's some overlap with what Dr. John once said, but I just wanted to go through it, so I want to say it and have it said. So first, I'd like to start by thanking everyone who joined us here at the 46th Annual Scientific Convention, and both participants from online from the United States and in South Korea, and those of us who are here today. This was truly the first ever international hybrid meeting for CAMA, and I agree, I think it's going to go down in history. It brought what I envisioned at the very beginning, bringing together speakers and participants from the US, as well as South Korea. And that connection, we talked about it in the last forum, but that connection with our heritage is just so important, and I think everyone here shares the same opinion. As you know, this convention was to have taken place July of 2020. We had planned it from a year before that. So 2019, July, we knew it was going to be in Seoul. We started negotiating, looking at sites. And, February, even up through February, we were thinking, February of 2020, that we were thinking we were going to have this convention in July of 2020. And a little thing called the pandemic, when early, January, a little bit of news, but then February and into March, this news headlines coming out of Wuhan, China, and then our first index case in New York City, and we knew that there was something a little different this time. So, and the rest is history. So we had then postponed and had thought 2021 July, a whole year postponement had to work. Well, it didn't. We postponed it down to the very end of 2021, which was December. And a little thing called Omicron variant tried to get in our way yet again. And we thought, actually really thought we're going to have to either cancel, which we didn't want to do, but yet again postpone and notify the speakers, and that we were having to then look at another date. Well, fast forward, here we are, 3 days of CAMA convention. I'm very proud that we were able to carry it out. And I'm really, truly thankful, grateful for everyone's contribution and support here. We already mentioned about the CAMA Executive Committee members who actually traveled and even facing potential 10-day quarantine, and yet they wanted to come, they came. All the work that led up to this convention, the whole team worked tirelessly. I mean, there were just from A to Z that needed to be addressed, and whenever I said, we need this, everyone jumped, contributed, and got it done. And I talked about resilience. I think tenacity might even be a better word that our EC exhibited through this. And again, this truly historical CAMA convention that we just completed. And I just want to actually especially thank our EC members who are here, Michelle Kim, who's the convention chair and president-elect, Jennifer Lee, Ara Lee, who's the scientific chair, and Cecilia Yun, the treasurer, who has done everything else, and Dr. Ji-Won Kim, who's the research chair, who actually joined us online. I was happy to see that. I do want to thank the board of directors, and special thanks to the chair, Dr. John Won, who's leaving, running away. He braved his way to Seoul, demonstrated truly his utmost support of us. And I also want to shout out a special thanks to our executive director, Sun-Hae Lee. She doesn't sleep. I'm convinced she doesn't sleep. Her hands were in everything that we did. We mentioned about the incredible help that Korean Medical Association, led by President Pil-Soo Lee, and his team, supporting the tedious process of quarantine exemption, getting the approval from the Korean Ministry of Health for the limited number of us who were going to travel. And of course, in the last moment, needing the help of the Consulate General, Ambassador Won Sam-Chang, and Mr. An being woken up at 3 a.m., and they remarkably got really all of us through. A few had a 24-hour quarantine, but in the end, when they got released, they no longer had to quarantine. And in fact, those of us who came to Sheila had to quarantine a little longer because our test results came back so late. And Professor Young-Sam Kim, he is just incredible. I truly think that we would not be here. I wouldn't be talking to you right now if it weren't for him. He was just detail-oriented, so meticulous. He would check, and he would check again and make sure that it was all the T's were crossed and the I's were dotted, and he was incredible. And really, I think it realized my vision that I set out to do, is really bring us back to our Korean heritage, that connection, and I really, really wanted to have a convention in Seoul. And for hybrid and the pandemic, but we did it. I think that's all I'll say. I think you guys are waiting for lunch, so I wish every one of you and your family and your loved ones really my personal best, and hope that 2022 will be a prosperous, peaceful, and healthy new year. And we have the incoming president, Michelle Kim, who's going to lead us through 2022.
Thank you so much, Dr. Choi. I can't think of a better way to end this fantastic convention and to think of 22 than best wishes for health and for happiness for our CAMA members and for their families and friends. I must say, this has really been an extraordinary 3 days. From the Pacific collaborations with the US and Korea, to the speakers and the quality of their scientific background and their expertise, to the time differences and the sort of constant calculations of 14 hours plus and minus, and ensuring that we're speaking at the right time. And really sort of the quality of the educational program, that you're having these amazing scientific lectures by experts all over the world. But then you're also having these deeply personal panels where people are talking about their grandmothers and the impact of their family members who emigrated to the States. So this has really been quite special. I agree, groundbreaking. And, and I think it just provides so much hope for the future. We saw today some of the work that our students and the up-and-coming talent are, and so that just provides even more hope and optimism, I think, for what could be in the future. I really must congratulate and thank President Mary Choi. What leadership, vision you've had during these past 2 years. And really the depth of your commitment and dedication to CAMA, to your vision of what you thought CAMA could be and CAMA is now, and also your vision of what this convention could be. And I really cannot say enough as to how much I respect you and I look up to you and your leadership. So thank you so very much, Mary. This was a very special way to learn from you. And I know that I speak for many of the EC committee members and for those who we watched you lead over these challenging 2 years, and it was really, there were a lot of curveballs in there during your tenure, but you navigated it with grace and with poise, and thank you so very much. I think that, again, as a role model, especially as a woman in medicine, I really can't say enough of what that has meant to me and to many of us. I think that we need to recognize also Dr. Augustine Choi, who has been really quite an ally as well, and really tireless in helping to create this sense of community and his passion for medical education. And so, Dean Choi, you've been just an amazing stalwart in this convention as well. Of course, Dr. John Won, as we've mentioned before, the chair of our CAMA board, and with just many, many years of service and his unwavering commitment, again, to having CAMA evolve towards what is perhaps a slightly different entity from what it's been in the past, but perhaps something that will, again, build a sense of community and also, evolve into something that is different and hopefully, better. And so I very much look forward to working with all of you over the next year as we plan the next convention. The EC team, those who are here in person and those who are back at home, Doctors Jennifer Lee and Cecilia Yoon and Jiwon Kim. There were some really late nights in there and some very long days. I hope that we can celebrate some of what this convention has been, and certainly, we'll have many more late nights, I can promise you that, unfortunately. Ms. Sunny Lee, I think, again, has been the heart and soul of this organization and ensuring that the many administrative details go smoothly, especially for these unprecedented times. So I think, just to wrap up, this has been, a really groundbreaking convention, and I hope that we can do the same next year in 2022. In this convention, as you can see here by the banner, this really was focused on diversity, innovation, and cure. And so I think we really can't do much better than to build upon that and to reinforce these themes and perhaps also to ensure that we are having access, that we have quality, that we have equity in everything, whether it's patient care or in our opportunities for our trainees. And so I hope that we can build on that, that we can build that sense of community and continue to collaborate to really fulfill these very worthwhile missions. I really continue to be amazed and inspired by the physicians in the audience today, the physicians who are hundreds of miles away and those who are here in Seoul. And I hope that we can leverage all of that experience, expertise, collective sense of kinship to really share that with the rest of the community at large. So as Dr. Choi did, thank you so much for your participation, your dedication. I hope that we can count on you for next year's convention as well. I had a conversation with Dr. Choi yesterday where unfortunately I told her we were not quite letting her go yet. But I think that this will be a very special convention as well in the future. I'm going to perhaps leave you with a challenge just to stay involved and create that sense of community wherever you can. There's already been such strong community, I think, in the last 3 days, and it would be lovely to be able to build on that for the future. So I think, thinking of perhaps about the future, we hope to have a really scientifically rigorous, communal, and high quality convention next year, and look forward to sharing details of that convention with you shortly. So without further ado, I'd like to introduce Dr. Ara Lee, who will now close the session. Thank you so much.
Thank you. There are, I just have to share that I find it very interesting that there was an afternoon when I was at Cornell when I got a phone call from my then department chairman, Dr. Augustine Choi, who called me into his office and said, Ara, do you know about CAMA? This was in 2016, and he asked me to give a talk. And now here I am, 5 years later, working on the executive committee under Dr. Mary Choi. And I want to thank both of you for introducing me to this wonderful organization and for helping me be a part of it. And I hope that those who watched our scientific convention on YouTube feel an equal sense of community and a desire to be more involved, because we welcome that. I do want to go through and thank and acknowledge our wonderful sponsors who helped to make this convention possible and who really stayed with us, stayed the course with us over this very difficult 24 months. Our Diamond Double sponsors, Denise and Michael Kellen Foundation, the New York Presbyterian Hospital, Weill Cornell Medicine, and Weill Cornell Medicine Qatar. Our diamond sponsors are the Hospital for Special Surgery, the Star Foundation, the Weill Cornell Medicine Department of Cardiothoracic Surgery, the Weill Cornell Medicine Department of Radiology, and the Weill Cornell Medicine Department of Reproductive Medicine. Our platinum sponsor, the Robb Family Fund. The silver sponsors, Robert and Christina Dow, Friedman Family Foundation, Weill Cornell Medicine Department of Emergency Medicine, Weill Cornell Medicine Department of Otolaryngology. Our bronze sponsors, the Weill Cornell Medicine Department of Dermatology, the Department of Neurology, the Department of Ophthalmology, and as well as the Department of Pathology. And our sponsors and friends of CAMA, Dr. Ingrid Chung, Dr. Soo-Yeon Kim, Dr. Chung-Myung Lee, the New York Presbyterian Brooklyn Methodist Hospital Department of Medicine, and the New York Presbyterian Brooklyn Methodist Hospital Department of Surgery. I'd also like to give a very heartfelt thanks to the Sheila Seoul and the staff here for helping us through these very difficult 2 years and for being so accommodating and so understanding of what we were going through and really helped to make this possible. Dr. Mr. Il Kwon and Ms. Joo-hee Chung. And for our TSM staff and crew, led by Mr. Dong-Hwa Seo and Mr. Sung-Soo Kim and all of the wonderful team, thank you so much for helping us all those late nights going through this very difficult hybrid program. We greatly appreciate your efforts and your help. And of course, this is not possible without all the support from our wonderful CAMA Board of Directors, particularly under the chairman of Dr. John Won, who has been stalwart and really determined to not let us let us down at all. Our amazing panel of speakers, thank you to each and every one of you for all the difficulty with the communications, with the time differences, but for really being so willing to adjust your very busy schedules to a difficult evening program in the States, and for logging on and joining us and watching us and supporting us. To Mary Choi, Dr. Mary Choi, you are an inspiration. It was really, thank you so much for sharing your vision and your dream with us, for bringing us on this truly incredible, hopefully once in a lifetime journey. Because I don't think any of us can do this again. But you have truly been wonderful. It is my absolute honor to call you my friend, and I thank you for that. To my EC teammates, both at the States and here, I have had so much fun with working with all of you, and I'm sure that I feel very close to many of you I did not know before starting CAMA. Mary brought us together, and I do feel that we are now a team. And so Michelle, to Dr. Michelle Kim, our next CAMA president, let's go to 47. Thank you very much.